non-exec directors then, to actually think about the right people. And actually, they are quite permissive. So if we need to put people on who are not on this list, we can do that. But also the opportunity when we get to probably July time, we will kind of have the final version. So any thoughts, Sue?
Yeah, and I have shared this. I think there's something around making sure that when we do the revision, obviously my committee will significantly interface with Rob's. And so we will need to do a check to make sure there's no duplication. But additionally, when I went through the terms of reference, which I do have the strategic one as well, one of the things that really stood out to me is if we're in a position when we actually reset them to really think about making them simple English. Because almost bringing to the very fore of the document, what is the purpose? It's at the moment, it's sort of 3 stages in. I think up front, what it is, because this is a different organisation with a different commission. And therefore, I think being really clear about that when people make that reference would be helpful. And I will share, I've done some more detailed stuff specifically around with conversation with Des. But I just think we can, it can be really easy to put everything in. And actually, I think there's some benefit in stripping it back and being really, really tight around this is what the purpose of the committee is for. This is the parameters within which it functions. These are the people that will be making the decisions on behalf.
I think that's really helpful.
Yeah, I do too.
Michelle and then Bev.
Yeah, no, thank you. And it's good to see these. And I really quite liked the links to the objectives that we've just spoke about. So we just need to, that's really helpful. But I do take on Sue's point and sort of endorse that. But my first observation was that it would be useful because some have got a bit of a schematic on and some haven't, around a bit of a schematic about the thing that the subgroup. I don't want to go too much, but sometimes that makes it more live and picks up some of Sue's points for that triangulation with other committees. And so the other thing that would be really helpful as well is that overarching organogram in relationship to where decisions are made and where that triangulation happens. Because I think that would be really helpful to clarify. So once these have been agreed, I think the next piece of work to do very quickly, and I don't, one side of A4 is just that overarching governance process in relationship to that decision-making flow will be helpful.
Well, I think that's really helpful, and we have started a piece of work which is progressing at pace, isn't it, Anya? Yes. Which has been around exactly what you're talking about, Michelle, which is around what exists underneath the committees, what supports the committees, what's that wider infrastructure of meetings we have within the ICB from the point of view, and I think, I've said this a few times, is there is something about making best use of what we have, but also understanding that we probably have far too many meetings. And actually, there is something around if we have a meeting that's just because of a function, then we probably don't need to have a meeting. We just need to work out where the function best sits. So some of this is about finding a home for some of the stuff that we've got at the minute. But I do think that's a really important piece of work to share back with the board is understanding everything else that kind of happens. Because in particular, I think there's something around that partnership space kind of moving forward. So where do the conversations take place, which is around, our future commissioning role, the transformation stuff, but also where do those touch point conversations happen with our key partners that enable the influence to kind of come in. So timescales wise, Anya, I think we are progressing well. Do you think we'll be in a position to kind of share an outline of that for June?
Mike's nodding, so I'll say yes.
I can say July.
Just really quickly, there's a whole tranche of work around this governance infrastructure to align to the new model and the new committee structure. So we've started that as Katrina and myself. Katrina as audit chair have had a brief conversation about the golden thread and interconnectivities. There's one extra thing I think that's really important. It's a real art, so in terms of simplifying, which is why some of the tabloid Fleet Street journalists were paid the most, because they simplify often complex things without losing meaning. But that's the challenge for us to come up with. The extra bit, I think that's really important. is to be really clear about a demarcation between what committees or groups or whatever forum we've got our decision making and what are advisory, and be really clear about everyone understands what their role is and the interdependencies within that system. And we'll get that on a page. That's the challenge for us. We will look for June, but I'm also conscious that if we're bringing, once people have had, particularly the committee chairs, have had 1 or 2 meetings of their committees to sense check, do these terms of reference work for you, or has it bedded in? We intend to bring that back in July. So there's a judgment about whether we bring it in 2 phases or one altogether, and be guided by you, Chair, ultimately, and the committee chairs.
Okay, and I think there's probably something as well, Des, around the scheme of delegation to understand the permissions that kind of exist. And I think that's quite important, where very often we will make recommendations in committees, but actually the level of the amount we're talking about means that it tips into board. But I see that very much as the expert committee has recommended. Actually, the board just needs to exercise the function of enacting that recommendation. So that would help.
Just build on that point, just for completeness, that obviously it's really important we don't duplicate things, but also what we're trying to map out from that is to make sure that nothing falls through the cracks as well. So it's both those lenses that we just need to get that one page and those dependencies which Mike and the team are working on.
I'm a great fan of grey areas. Grey areas is where stuff happens, and if you stand on somebody's foot, somebody has to move their foot. So action happens to grey areas. So I'm a great fan of them. So, okay, there's just one other thing for me before we go them one by one. There's just a consistency. So there is something, I think, in all of them around just that permission for the chair to attend a meeting for an assurance purpose, that we just need to have the same wording in all of them. Some of them don't have it. I won't take offence. Some of it has it in a really clumsy way. So we just need to be able to just kind of track that through. Beth?
The caveat to that, I think, would be the audit and risk committee, because no chair really should be going there.
Yeah.
I did have some other points, but I'm happy to bring them on when you talk through the.
Although it's I know it's not in audit, it's in finance, performance and contracting. It's not in audit. I just think it's just about, there's a different way to get assurance from the audit committee, which is about attending the meeting. Okay, so let's go them one by one. So this is as quick or as long as you want this to be. So remuneration committee, anything you want to say, Dean?
It's all fine.
Yeah, nice and compact. Remuneration committee. Executive committee, Teresa. Less compact. Yeah.
It is what it is. It's fine.
Yeah. Party committee, even less compact than anything else.
Yeah. Okay. So I don't like them. I think it's fair to say that Amanda and I are on the same page. We've had a discussion. We got to the point where we absolutely looked at the membership, which was the ask. We've looked at the quorum, which was the ask. Beyond that, I need to meet with the team. I need to understand what our statutory obligations are, our commissioning obligations, and actually form the agenda around that. I'm 100% so. I'm a very simple person. So we've got some time out with the team. We've got a development plan is to me first week. I'm on holiday 2 weeks. And to the plan is to make chair in July and report to the July board.
Yeah.
And do it properly.
And I guess that's the July version of the terms of reference that kind of comes back. I think this is about, you can proceed with business if you need to on this, but it needs some work. Yeah. Okay. Finance, performance and contracting. So
yeah, I've shared sort of the highlights, but we obviously had the chance to also think through, having had one committee meeting, and we've already made some changes, especially around membership, and also going to ask for some slightly different papers that will be coming because of the change in the business.
Yeah, that's good. That's good. So the brand new one, I mean, some of these are based on previous ones, but the brand new one, Anya, in Rob's absence, I'm going to ask you to pick this one up because you've been working with Rob on this one. So anything you want to say about strategic commissioning committee?
I think just to echo the points that have already been made, that it's absolutely fine for doing the job now. It will develop as we get in, because we haven't held the strategic commissioning committee as yet. And obviously this is the brand new one, as you just articulated, Chair. So it will develop, but content as it is now to get going, as it were.
Okay, so the board happy to approve all those terms of reference with the caveat that we'll probably get a revised version back, or we will get a revised version back in July.
For completeness, we ought to cover audit and governance.
Audit and governance, fantastic.
Chair.
Audit and governance. It's because they're all stuck together. There's too many of them. We'll get there's anything.
So comfortable with everything within it. It does need simplifying, and the piece around frequency of the meetings to tie into others is, once we've done that piece of work, we'll be able to confirm that piece.
Superb. So we're happy with all the others. And transition committee, Jane.
Yeah, I'm happy with that.
Yeah. Okay, so we're happy to sign all those off, including the two that I forgot about. One of which I chair, but never mind. We'll move over that one very quickly.
Sorry.
Go on, Sue.
It's just a question really of Mike, and it's whether, given all of the committees have standard statements in them, whether it does make it easier if they are one document that refers to everyone, that everyone plays back to, so that the focus of the committee terms of reference become really tight, because I think some of the elements get lost. So if you think about the administration of it and those sorts of things, they actually affect all the committees. They're not specific to, and it's a presentational issue, and it might just be worth. It's just a question if it would be possible, and I'm coming at that, I suppose, background working around HR policies. There are standard elements in every HR policy. The repetition of them is often unhelpful. People lose sight of reading it. Whereas standing it out sometimes means this applies to this. It creates that connectivity.
I second that. I think that's a great idea.
Yeah.
I mean, happy to have that conversation out.
Just to consider.
Part of this development, because I think there's pros and cons, and we need to weigh them up. I'm absolutely not wedded to one way or the other, but there's some comfort also in, although there's repetition, if somebody takes one policy or one term of reference from our website, it's making sure that they're aware to look and marry that up. So it keeps, it's about, it's a sort of direct word, but control of the, and again, it's probably a conversation with our internal auditors as well as to how they would expect to assess that, but happy to pick that up.
And if we pick that up, we can pick that up, and actually that's probably part of what we get back in July, isn't it, in terms of that. So, Zoe.
I hope it's helpful. I think there's something about that simplifying bit, which has already been expressed, but there is also something about we are trying to make this easy to understand, not just for the people in this room, but for members of the public and for our colleagues on the ground. And there's something for me about the language that we're using and making sure that we're being mindful of how readable that is for our population. And we haven't really done it before, but there are a number of organisations that specifically look at what is the reading age of the documents, type of language being used. It might be we want to have something alongside what we're talking about, that actually the patients and public that we're working for know what this all means.
So I think we've got huge opportunity, I think, in terms of what comes back to us. But I suppose the agreement today is that we have established the committees, they all have a terms of reference, and actually they are all good to go and operate, and that will be at different paces doing different things. So I think, having sat in your committee last week, I think it was, Sue, I think very much, I think my reflection is there's something around closing down old world business and then starting to prepare for new world business as well. I think most of the committees will be in a similar place. So some of this is about, by the time we get to July, it will wholly be focused on the new ICB, but this has been a really important kind of significant kind of step forward in terms of that. So thank you for everything you're doing and the work that's happening around terms of reference. Okay, we'll move on to chair report. So I'm going to take it through. There's a couple of things I just want to kind of pull out. One of which is, I think we did it informally at the last meeting, Zoe, but just to welcome you on behalf of our primary care partner member in terms of the board. And I think primary care, and when we talk a little bit later about neighbourhood health, is clearly one of our most significant relationships that we need to grow and develop. I'm really pleased that you're part of this board, and I think very much it's about them thinking around the opportunities to create for that wider family of primary care services, so dentistry, optometry, pharmacy, in terms of our future direction, in terms of strategic commissioning. So really pleased to have you here. We are moving forward now in terms of filling the vacancies that we have around the board table, in terms of the two executive kind of vacancies that we have. So I'm confident by the time we get to June's meeting, we'll be able to resolve some of those vacancies around the table. I'm not going to touch on organisational change because it's Jane's thunder and I don't want to steal organisational change. I do want to kind of pull out the leading from the middle bit, Jane, I think, in terms of the work of the people team. And one of the first things I was asked to do when I became chair a year ago was to speak to a group of from across our system. So organisations in the voluntary sector, our NHS trust partners, mental health, community services, a group of people who'd come together for an ICB facilitated programme which was about developing middle level staff in terms of leadership skills. And it was a really, really privilege to kind of talk to them at that first event, to talk about my own journey around leadership, but also to recognise that at this point in time, with all the change going on, we have never needed leaders more than we need them now. So how do we take those people who are interested in leadership, who want to test it out and try it, and actually support them to have that experience? I can't believe it's a year ago, but they asked me to go back and speak at their final kind of celebration event. And I have to say, I was incredibly humble and so inspired by the stories I heard from that. But actually, despite all of the chaos that's been going on in the ICB and the wider system, that people had actually undertaken a leadership programme that was about development, that was about testing them, developing skills and experiences. As part of this, I did actually offer a mentoring opportunity to somebody from the ICB. And I have to say, it's been one of the most positive, reflective experiences of my own career to have somebody say to me, "Why do you do that?" And have to say, "I have no idea why I did that." And actually, so I just wanted to use this opportunity to say thank you, I think, Jane, to Emma Marshall, Gersh, Lisa within the team for kind of delivering this programme. But also, I think it reinforces certainly our commitment as an ICB, and I know from our partner organisations that actually investing in our workforce, our current workforce and our future workforce, and actually creating those opportunities for future leaders has to be part of where we go to. So I just want to say thank you to everybody who did that. It's been a real privilege. And it was great to be part of that. So I did want to share that with the board. The other thing, there's two things I wanted to share which are not in my report, so forgive me. One of which I think Teresa will talk a little bit more around the visit we had last week from Claire Fuller around neighbourhood health readiness. I want to say that it was such a pleasure to be sitting in this room to hear the feedback from Claire Fuller as to how we were progressing as an ICB and all the elements that we focused on in terms of data, relationships, governance, our clinical model, to actually, have the opportunity to hear how well we were doing. But also my reflection is, and there was a key point I think Claire Fuller talked about, which was we do not shout about what we do and we do not celebrate our success. So actually, whatever we do as an ICB moving forward, my encouragement is to everybody is we are doing some great stuff. Shout about it. Actually, it's not about it's pride in the positive sense, but also we need to recognise our achievements. And if people need to hear anything now, it's that positivity that actually we are doing incredibly well. And it was great to spend a day with partners in this room talking about the vision for neighbourhood health, our role as Strategic Commissioner, but also to really touch base with all the work that's happening all of our 6 places. So Teresa will pick up more about it, but I have to say I was very proud sitting in this room last week to hear what we've been doing, but also the feedback that came from Claire Fuller. And I know quite a few of you were with us there as well. The other thing is, so overnight breaking news. So Nigel, if I get this wrong, help me out.
Yeah.
So HSJ Awards last night, Interweave, Michelle, which is something which I know that you lead as an organisation on behalf of the partnership, of which the ICB, it won an award for driving interoperability and standards through digital. I think we just need to say well done, and that's really fantastic. And actually it bridges the gap, I think, doesn't it? I think it's been recognised as something which nobody else is kind of doing. So a big thank you to everybody who's worked on that, and hopefully at some point today they will find their way back from the ceremony. I'm not quite sure when, because I did see some pictures of them, and they looked as though they were happy to have won this award last night. So thank you for that. So that was all I was going to say in terms of the chair's report. Are there any questions? Super. Teresa, we move to you.
To me. So the report as it stands in the papers, I'm not going to go through. We have got a series of presentations, however, to take you through. The first one, the response to Jim Mackey's letter. So we signposted this last month in terms of the ask around neighbourhood health. So we agreed at the board that we would share our response to that letter, and Anya will take us through once the slides.
Yeah, thanks, Teresa. And I'm not necessarily proposing to go through each slide verbatim. If you can maybe just move it on one, and then that would be helpful.
This is the wrong slide set.
Yeah.
That is the wrong slide set.
And if you've been in this room, stay unconscious. Can you? I know this is going to be challenging.
I'll see as it comes up, if
Yeah.
that's okay.
Okay, but if you need to do anything within reason,
I'll move.
Emma starts with that one.
Have you got Emma? Or do you need it? Yeah, perfect.
Sorry.
Yeah, no worries. If you could just move.
you notice that this screen is going quicker than that one.
No,
So that's part of the reason I'm not going to go through it verbatim. As you can see, it's pretty small writing. This was the template that was required for submission. So I'm sure we can circulate so that colleagues can read in more detail. And you will remember that we circulated the 5-year commissioning plan that was submitted at the end of March, and just in red that highlights where there is more detail in the actual plan itself, because of course NHSE have already had that plan as well. But I will just pull out a few things that I think are really pertinent. So just to set the frame, if you like, of the ask, we were asked particularly to focus on our strategic commissioning vision for the next 3 years and how we saw that developing, our neighbourhood health ambitions, any changes required to financial flow and or payment mechanisms, and anything else needed from the centre, as in NHSE and DHSC centre. So as I say, I won't go through the slides verbatim, so Emma, you can just sort of keep flicking through them, just so colleagues can just get a flavour.
Look at this one. It's telling us that one's not working, so everyone will need to swivel to this one.
Oh, right, okay. So firstly, I think that our plan does set out a clear strategic intent, and that is to shift to outcomes-led strategic commissioning, with the absolute intention of delivering population health improvement, reducing inequalities, but fundamentally financial sustainability, because we know we have that fixed resource envelope. So I think this is being ambitiously pragmatic, if I can put it like that. And absolutely a shift from what we would describe as incremental improvement to structural system redesign, with explicit prioritisation and trade-offs. And again, the detail is within the commissioning plan itself. Linked to that, there is a clear focus on what we're describing as high impact priorities. As we have shared before, delivery is concentrated through our 5 programmes of care, but particularly through those programmes of care targeting areas where demand, cost and inequality intersect most strongly. So that gives us the areas of focus, and absolutely all decisions being informed by population health intelligence, demand modelling and affordability. And we are expecting, as part of the vision, to see a shift in our commissioning model to transition to multi-year outcome-based commissioning, again with those clear priorities and reduced unwarranted variation across our patch, and a stronger use of the commissioning levers that are available to us to manage demand, improve value and shape the market. Jason has just touched on neighbourhood health, which we absolutely see as being the system centre of gravity, if you like, the primary delivery model for transformation across our system, clearly being crucial to delivering the national 10-year plan, and particularly shifting from reactive care to proactive, coordinated and community-based support. We received very positive feedback, as the chair has just touched on, but the focus continues in the areas that we set out as part of that visit last week. So a real focus on high risk and high intensity cohorts, particularly around frailty, long-term conditions and high intensity users, prevention and early intervention, and integrated multidisciplinary teams, and clearly an ambition to reduce avoidable hospital activity. absolutely, and this was heralded last week, that our neighbourhood model is enabled absolutely by population health intelligence, shared data and digital tools. And I won't again repeat what's already been said, but we identified within the submission the progress already made, and particularly around our integrated neighbourhood teams being established in all places with defined footprints and early delivery underway. Demand management is key as part of our commissioning intentions for the next 3 years. And as I touched on, a clear focus on reducing hospital demand, because we know that that is our key point of issue, if you like, and bed use, rather than looking to expand capacity. And as I've said, investment in prevention, community-based care, pathway redesign and digital access. So our delivery approach, as we know, is through the 5 programmes of care, but absolutely through a disciplined transformation portfolio with clear outcomes, governance and milestones. We have early progress, even though we haven't established formally our programmes of care around neighbourhood health development, as has already been well rehearsed today. Planned care redesign and outpatient reform, which is already underway, urgent care system review and mental health and neurodiversity pathway improvements. All of this is underway despite our programmes of care not yet being fully established. And we also have agreement to system transformation programmes, and these have been shared as part of the planning round with NHSE. And those again correspond to the priorities that have been outlined around neighbourhood health acceleration, mental health, particularly out of area placements and an ADHD reset, outpatient transformation, and enablers to all of that are a community services review and reset, workforce sustainability and reset, and from a provider point of view, a focus on provider corporate services review and reset. So all of those are in the submission as well. I've touched on the key enablers around workforce and community services redesign, but also, and it's helpful that we come on to this shortly in the voice of the lived experience, a digital front door is an absolute must and is absolutely fed back through our population, and clearly the NHS app offers us an opportunity to do that, and we will come on to it in a second. And another enabler is again thinking about the financial approach and evolving support to resource the shift from community, the shift to community, not from community, the shift to community and outcome-based payments models. And finally, just to identify our key risks and dependencies. So clearly, we have a significant financial constraint in our system and structural deficit, which again brings us back to that focus on credible demand reduction. That has to be a priority from the outset. There is clearly a delivery risk linked to capacity, partner alignment and our overall system maturity, but we remain confident that we are working through that, and a need for national support and flexibility to enable prioritisation, disinvestment and transformation at pace. So I hope that's a helpful summary, but we will of course share the detail for you to read through. Thanks, Chair.
Thank you. In very small font.
Yes.
So if anybody could read that on that screen, I'm very impressed.
Yeah.
I mean, did you want to come in, Teresa? Because I think it would be helpful to segue some of the Claire Fuller.
Yeah. The two go hand in hand, because as Anya's alluded to, neighbourhood health is the organising feature, isn't it? Particularly of our transformation programmes and what we need to deliver. Not forgetting the context of our system, which is both financially and performance challenged from an acute organisation perspective. So the transformation programmes underpin moving the system into a more financially viable and performance enhanced future. So the neighbourhood health stock take review visit. So we had Claire Fuller, who's the National Medical Director, James Kent, who's the National Advisor within the Strategy Directorate at NHS England, and Paul Marbach, who is the Director for Neighbourhood Health at the DHSC. So we were specifically identified as the first test site system for the national stock take, because we already have well-established relationships with the national team around neighbourhood health. So there was some trepidation about going first, putting your hat in the ring and being the first to be assessed in this way. But the review team have provided very positive feedback on both the quality of the programme and the way that the session was organised and facilitated, which doesn't mean to say that there aren't things that have been identified that we need to work on. Particularly, they were probing things like the accountability arrangements, our thoughts on contract mechanisms. There's more guidance to come nationally on the contract mechanisms, but they were exploring our thoughts, and I think actually, hopefully, what would be useful within that additional guidance for the contract mechanisms. But the accountability arrangements, the role of health and wellbeing boards, our joint committees, things like that, are things that we still need to work through. However, they particularly praised the strength and professionalism of the presentation and the organisation of the visit, the breadth of engagement across the wider system and place partnerships. And, you know, for anybody who was here, I think it was clear, wasn't it? The engagement, the attendance just underpinned that, and the seniority of that attendance as well was particularly commented upon. So they commented on the competency and credibility of the ICB leadership, the significant progress already made across Humber and North Yorkshire in developing neighbourhood health, the openness and candour of discussions throughout the day, because we just felt that that was the right thing to do. We needed to be really, really clear of what our challenges were, any gaps that we felt we needed support in addressing, and the clear strategic narrative, the strong foundations and coherent delivery plan. They identified a number of areas of what they classed as emerging best practice and system strength, which were the strong population health management and analytical capability to support the neighbourhood developments. And actually, that's something that we need to note, because that strong data and analytics capability has supported our 5-year strategic commissioning proposals in full, not just around neighbourhood health. Established partnership arrangements with local authorities and place partnerships. Clear progress on neighbourhood geographies with defined neighbourhoods as an organising footprint for delivery. Clear clinical models centred on proactive care, integrated neighbourhood teams and improved crisis response. Strong GP access performance and growing primary care leadership within neighbourhood development. Evidence of strategic thinking around future provider and neighbourhood contracting models. System-wide focus on high-intensity users and proactive management of avoidable demand, which are part of our transformation programmes. Early alignment of outpatient transformation with neighbourhood working, and a well-developed plan for neighbourhood hubs and estates planning to support integrated delivery, all based around an understanding of need. So I think in summary, we've got really strong foundations. We've got a long way to go. I don't think, you know, in this positive feedback, nobody's underplaying that we're still really at the start of the journey. We're not anywhere near the end. But the important piece is around the strong foundations in place, and the fact that we genuinely recognise that it's really important for us to continue the joint working that we have with providers, primary care, local authorities, and our VCSE partners to actually bring all of this to life and demonstrate the outcomes that we want to see. So that's all I wanted to feed back formally. I just open it, see if there's anybody who attended wanted to actually give their views and thoughts.
No pressure, you don't have to if you don't want to. Teresa's captured it, that's fine.
Who was here, actually? Was that
Zoe-
you,
Zoe was
Zoe?
here.
Yeah, okay, yeah.
Yeah, Zoe was there, wasn't she?
Yeah, I agree with all of that. I think it was really heartening that they were coming in genuinely interested in what we are doing, and that they are still trying to form their strategy nationally.
Yeah.
And what they're trying to do is find systems that they know well, that they have confidence in, and are asking how we're doing it. And you're right, the atmosphere in the room wasn't, but look how great and shiny it is, we've got it sorted. It was very much, here are the areas that we think we're doing well in, and that was reflected, and here are the areas that we still need to build on. And I think actually knowing that it is an evolving picture at national level is really helpful for us, rather than feeling that we have to fit into a box. And it probably comes back to the conversation at the last board meeting about, what kind of ICB, what kind of board do we want to be? We want to be the board that's right for our population. And I think actually that gives us further permission to do that, because it isn't fitting in a box. So I'm looking forward to them coming back and us being able to show the progress we've made.
And that's for the proper assessment, isn't it? This was the helping them formulate the assessment. So let's hope this is positive when they come back in the summer. See what happens. There's a challenge there, but better.
Was anybody from the regional team?
Yes, there
Yeah.
was.
All right.
Yes, there was.
What's the relationship with the national to the regional? Because it'd be I'm really glad they were there to hear that. And hear that kind
Yes.
Yeah.
Uncertain, I think. So at times, and I think we need to recognise everybody's going through significant reorganisation. At times, it can feel a little bit disjointed. By virtue of that, what I mean by that, to give you an example of that, Bev, is the ask from Jim's letter, which specifically was around demonstrating our proposals around neighbourhood health, and at the same time a visit for the neighbourhood health team to take a stock take. So it felt like two different strands that, that's our perspective here. It might be more coherent nationally. Yeah. I think if Alex was here, she'd be able to explain the relationship with the regional team much better than I can, because that's what she's obviously doing day in, day out.
The other question, Chair, if I may, is around the neighbourhood health. And I've linked it to the performance report later on, in terms of the question I've got is, are we clear on what improved outcomes we will see or are seeing in the neighbourhood to help with the urgent care, which obviously we've seen an increase in some of our providers. So again, I guess it's just a question around strategic commissioning.
Yeah.
Commissioning for good outcomes.
Yeah. That's within our detailed neighbourhood health plans. We can share the slide pack that we went through in it links to our strategic commissioning as well, with the parameters around obviously addressing the population health need, but also some of the efficiency and productivity response, which is where we're actually going to drive some of the financial sustainability. So the impact on providers, particularly the acute providers, are some of the outcomes that we are looking for to support the financial sustainability into the future.
And longer term, neighbourhood health will need to demonstrate the impact it has on that. So actually some of this is around that longer term vision, is around how do we start to do that? Because this is a cultural challenge, isn't it? But also there is something in this which is around, there were no surprises, I think, for us, that in lots of ways we've already said that piece of work around looking at governance and looking at the role of joint committees and health and wellbeing boards is something that we're really wanting to work through with people, because in a way, and it's all about our structure as well, what we have designed is the right vehicle to deliver high class quality outcome focused neighbourhood health. And this is now, as we get towards mobilisation, is and some of the feedback was we have all the pieces of the jigsaw. The picture is emerging, but actually we are probably well placed. We are starting from an informed place rather than from scratch. And I think that is a reflection of the work everybody's done. And just to say a huge thank you to Alex Seal for kind of leading this, pulling this together. It was no mean feat getting 50 people in this room doing a presentation, and actually all that feedback came from, I think it was 5 hours in this room. So it just shows you how amazingly well Alex kind of did. It might be worth us, I think, thinking about the next board that Alex is now a member as a participant, to think about probably an update to the board on neighbourhood health, just to see. I think that would be really helpful, so you can see where we're And actually it'd be helpful to think about that from the primary care perspective, Zoe from the private perspective, Michelle, in terms of how that's going. Probably not a show and tell for each of the 6 places, but actually I suppose this is how we capture it as a whole. Sean, then Sue, and then Teresa.
Thank you.
Yeah.
Just a couple of observations really. I think we had the discussion after our committee that each committee needs to assess itself as it's doing its business, that it is delivering against some of these commitments around shift.
Yeah.
And it was just something in terms of language. I think when we use the term disinvestment, it can sometimes be heard as withdrawal. My sense is that the commitment that's being given is it's about an alternative approach to investment for different outcomes.
Yes.
And I'm just really conscious because it is a shift, and we've got to talk in language that is better understood by people not in the middle of it.
Yeah.
We thought it's a positive approach to actually commissioning a different outcome that we know has more value to the people using services. So you've already said we're not talking disinvestment, we're talking it's an alternative investment approach to deliver the outcomes that we know our population have asked for and need.
Yeah, and I think that's really important. I think one of the things that strikes me is we need to tell the story. And actually, we don't tell stories particularly well, but there is a story around the outcomes, the benefits of a new way of working, which actually is really compelling. But actually, unless we tell the story well, people don't come on the journey with us. So I think that's a really important point. And actually anchoring this all back down to the core purpose of the ICB moving forward. Actually, this is all the pieces of that. And some of this is actually about how we reorder and better use what we have already, our strength in primary care, our strength in communities, our strength in the VCSE, the strength of our relationships. That's what came across really strongly from Claire's visit, was the fact that, our focused partnership approach to population health, the emphasis on data, and digital and the shared patient record, all of these things are stories we need to tell about the difference that, people will feel in our communities. And I think that is the key to it. I think it's a really good point. I'm going to Sean, then Dean, and then Teresa is going to talk to us about the health bill.
Yeah, just picking on what you just said there, Chair, and obviously specific response to Bev's question. I think we are absolutely well placed, and the presentation that Andrew gave included the submission around neighbourhood health, but we had our stock taken in advance of us and everyone else having to submit that nationally. One of 3 areas, as Teresa mentioned. So everyone else is having a visit on the back of what was submitted, and we did it the other way around. So just to illustrate how we're the head of the pack. South Yorkshire, for example, having theirs next week. I think the key thing around your question is that everyone's trying to work out this, and regionally they're not structurally set up to support this, which is one of the reasons why they're going through a reorganisational change to adapt, amongst other things, for this particular purpose. Although obviously we did have a regional rep here. So everyone's trying to work this through and identify their roles and perspectives and then what outcomes we want from it. So it is work in progress in a multitude of different ways. And I think how we reconcile this with other agendas is clearly one of the areas.
Well, I guess the other bit before I bring Dean is that everybody at government level, different departments are all talking about neighbourhood. And actually, there is something about there needs to be one conversation that is about neighbourhood. And actually, if we think about pride in place investment, the role of mayoral combined authorities, we think about health on the high street, what we're talking about is a neighbourhood health movement rather than an NHS concept of neighbourhood health. So I think one of the things that I said to Paul Marback, across government, was if we could join this together in one place and talk in the same way about neighbourhoods, we actually have a massive opportunity that actually the NHS is a part of. NHS is not the only person who is, and if we get this right, this is wider than health, isn't it? This is about skills. This is about where people live. These are a whole host of things that actually will make the biggest difference. And actually health is a part of that. It's not the only thing. And I think that's really important. Dean, last words on where we've got to in neighbourhood health.
Well, it was to do with the commissioning vision as well. I'm also sure if this is the right place to pick it up, Rich, picking up Sue's point about the when we've got a strategic vision and we're making progress, are we clear what our ambitions and milestones are along the way on that? And that might be more in the detailed sort of practice. Sometimes you've got a vision, isn't it? You can claim success on the back of incremental progress, but was it as fast as we intended or hoped?
Yeah.
And if we'd set our stall out earlier about making more rapid progress, we could push ourselves more on some of those. So, I don't know, in the proportion of staff that are in hospitals compared to community settings has changed by 10% or, by year, or whatever those might be. And I'm sure there's others on there, but I think it would be good to get some of that so we can set a pace as a new organisation rather than just record what we did that happened.
Yes.
Yeah.
And then I think the neighbourhood health stuff would be good at the next meeting, and also I think the Claire Fuller and team on the physical health, but there's the mental health, neighbourhood health sort of approach as well, and it might be good to sort of capture. I've noticed various pilots in there, isn't there?
Yeah, so there are, but just picking up on the words that you used, I wouldn't want anybody to believe that Claire Fuller and the neighbourhood health focuses on just physical health. It's not. It's integrated. It's not a separate to anything neighbourhood mental health. It is everything neighbourhood health.
But it's not. Am I right? I could have got this wrong, but not necessarily total. So there could be separate mental health neighbourhood, which is different to a physical, crisis bed, mental health neighbourhood stuff, which might be in a different place within the community to the physical, or is that my understanding?
And this is the problem. People use the word neighbourhood to describe different things. Is in some ways there is that core mental health offer which sits in neighbourhood health, and then there is that how do we deliver some services in neighbourhoods in different settings. And I kind of think we do need to recognise that there is some confusion around language around neighbourhoods, and actually, and the other piece around this, I think you make a really good point around anticipating, whenever the workforce kind of plan arrives. Clearly, there is an understanding that the workforce we need to deliver quality neighbourhood health is different, and actually there is something there around. We go back to some of that stuff, Jane. I think around that one workforce approach. How do you bring people from different disciplines who are the right people to be delivering neighbourhood health, who are not necessarily the people who are delivering at the moment, and actually what's that knock-on effect? So how do we develop a workforce which is neighbourhood focused, which is almost multidisciplinary team type stuff, not formally but almost kind of informally, and actually what's the opportunity we have? And we'll talk a bit about skills a little bit later in the agenda, but I think we are well placed to be starting to think about that very proactively. We aren't starting from scratch there, but I don't know you, Michelle. Some of the neighbourhood wording has been probably less than helpful to describe various bits and pieces that have happened.
Yeah, and it does get really confusing. And I think the clarification from Claire was really helpful in relation to setting out this. And we're not going to get it right. I think so we're not going to get it right the first time. There are going to be things that we've got to work through, and that's not just where some aspects of mental health fits, but where some other aspects of other elements fit. But it's about starting to get that bigger map. But I think that given the conversations that we've had, because you can't exclude it, because the physical piece and the mental health piece go really, really well together and one and the other. So we have to integrate it, and but then there's going to be some speciality. But you can argue that in relationship to acute services as well. Community. So I think that we are beginning to have the right discussions in the right place. I think it goes back to your earlier point, which is around that duplication and not having meetings for meetings' sake, making sure we've got the right people in the room. And I think what we're trying to do with the mental health partnership at the moment will really feed into that and be really helpful.
I think that's really positive.
I think just coming back to your specific point, Thea, it might be a feature of services within a single neighbourhood versus the services that are provided but on a multi-neighbourhood basis, and how people actually access those across multi-neighbourhoods. I think that's possibly what you're referring to.
Yeah, and that's the whole contracting piece, isn't it, in terms of kind of coming through. So Anya, I'll let you have the final words.
Sorry, Chair, I know you want to move on. I just think it was a really important point that Dean made, and I just wanted to signal that as an example, you'll have seen our overall strategy, and the North Star, if you like, of that strategy is improving life expectancy, but particularly healthy life expectancy. Now, on that point, you may have seen over the last few weeks, there has been some national data released, and we've been working through it on a local basis, where the picture is not pleasant around healthy life expectancy, that is actually reducing nationally, and we are feeling it more acutely in Humber and North Yorkshire in particular places. So what the team are doing are working through what is driving that reduction in healthy life expectancy. expectancy in Humber and North Yorkshire, and how do we need to replay that back through our commissioning intentions and those milestones? Because if that's our high level intention and we're already, you know, way off the mark with it because it's going backwards, what do we need to do and reprioritise, and what are the things that are within health's gift to do? Of course, a lot of those things are around the wider system, but again, it's how we share that information with the wider system. I think, Chair, you called it a bit of a call to arms, but also really forensically looking at, because we can't just say, well, it's all not working and it's going backwards. There will be some things that are working that have mitigated a worse position. So how do we understand what those are so we can continue investing in them and prioritising in them? But it's things like that. We'll share that when it's worked through. But that absolutely, it's that live, as Teresa touched on, the insight and intelligence piece that should be keeping us keeping those intentions really live of, are they still the priorities, and has anything changed as a result of the insight that we're getting? Sorry, Chair.
No, that's exactly right. And we'll bring something back. So working through about how we tell the story of life expectancy, because I think it's really important that we start to recognise ultimately it may be graphs, but it's people.
Yeah.
Judging by those stats, I think I've probably got a year left before I die. So just to put that out there, you can start to think about succession planning. See that to you. Okay, so
Sorry, Chair. Before we move on to the health bill, I just want to add one other issue, because we have received obviously expressions of concern from members of the public, particularly. So I just want to make sure that the board are aware. So the concern relates to the closure of some bed capacity within Bridlington Hospital. Just for everybody's understanding, these were extra beds that were opened during COVID to provide bedded capacity for patients who couldn't go directly home at that point in time. So York and Scarborough, a trust have made the decision to close those beds. There was a meeting at East Riding Health and Wellbeing Board last week, which recognised the public concern. Some recommendations came out of that meeting, including further public engagement. York and Scarborough Trust Board were asked to consider pausing the closure, but I think we recognise that that would be very difficult as the staff are being redeployed. Our position as an ICB, obviously, is that this is actually about services, not bedded capacity. And I think it comes to your point, you very articulately set out, you know, the decommissioning, actually, it's about reprovision in different ways. So I think the ICB is working with York and Scarborough Trust, both in terms of engagement in relation to this specific decision, but actually also about the future development of services within Bridlington Hospital, because the Trust is actually committed really strongly to the future development of services and see it as a key asset that needs to be well utilised. So I just wanted to make sure that the board were
important to cite the board on that as well. Okay.
So health bill. So just to set the scene, in terms of, this is a very high level summary of some key points. It's not meant to be totally exhaustive of everything that's in there, and it's I say high level really for sort of public consumption, to explain what is actually, if anybody has tried to read it, a very technical bill. And to actually understand everything in the bill, you need all the other health acts and associated legislation to go alongside it, because it is a very technical publication.
And it was referenced in the King's speech last week, wasn't it? So it's starting its passage through Parliament.
It is.
And this is the starting point, and it will go through parliamentary process, which may change.
Yeah. There are, we can have a discussion later today for any points of finer detail or interpretation that we may want to get into. So what it's trying to achieve, so modernising the NHS through the simplifying the national structures, reducing duplication, improving patient experience and safety, empowering local systems, and a key measure was around strengthening value for taxpayers by cutting bureaucracy and encouraging earlier intervention. So the earlier intervention piece, I'm sure we can all get. There might be different perspectives on the bureaucracy element, but I promise not to comment too much as we go through this. We can have a discussion later. So, as I say, just key headlines, some major structural changes, abolition of NHS England, many functions being moved into the Department of Health and Social Care. I think if you're reading the bill, it reads really strongly about boosting the powers of the Secretary of State directly. Reconfiguration of ICBs, which we are very much aware of because we are leading that, or living that, should I say, and also changes to foundation trust governance, with adjustments to governance, and that's particularly around the members and the word's gone out of my head. Governance. Thank you. I don't know whether that was expected or not, but I think it had been trailed.
Yeah, it was in the dash review, wasn't it?
It was in the plan, yeah. It's been hinted at a long time, yeah.
Okay. So the next heading is around data, digital and patient safety reforms. So the single patient record, I'm not sure of the timescale that this will be delivered by. I'm just looking at Nigel to see if there's anything you want to say on this point.
Well, the award that you referenced earlier on there is directly related to the single patient record, and it's whether it's interoperability that you want or a single patient record that's read or write. And that's one of the things that they're going to having a real look at about what this really means and what it doesn't mean. Like everything in life, it's only as good as if anybody uses it properly.
Yes.
And
everybody uses
we
it,
see that with any electronic patient record.
Yeah.
So actually, the aim and the vision is probably right, but actually there's a lot of cultural and behavioural work to be done on the ground.
Yeah.
I think the challenge though is that this is a national expectation.
Yeah.
That's the bit that it might be a long time in the delivery.
Michelle might know. Is this an interweave moment?
No, I don't know, but I think out of all the areas proposed, this will be the one that will struggle when it starts to go through the parliamentary process, to be honest. So I think what we're expecting is that something in relation to that will change.
Yeah.
Given sort of, I think what Anne says, that's its on. But please do not quote me on that.
No, and it's very much headline, isn't it? A draft bill is very much in terms of a set of wishes that then get debated and kind of lobbied on, don't they? So it's a starting point, isn't it?
So the patient safety bodies, HSIB transferred to CQC, that has been trailed for a period of time. One thing I'm left uncertain of, and I think it's Amanda, is the future role and function of the NQB, the National Quality Board. I know that they're meeting, it has been reinvigorated, but how that actually fits into the architecture is, I think, yet to be made clear.
And Teresa, just to add, there's a lot of conversation going on about the combining HSIB with CQC. I know because there's some quite strong feeling about independence around HSIB, so that's ongoing at the moment.
Because the draft bill also picks up the recommendations from the DASH review around, doesn't it, around patient safety and health watch and stuff like that. So it kind of brings together things that have been trailblazed before into one place that wants to legislate, doesn't it?
Okay, so patient voice and accountability, as you've just said, the abolition of Health Watch. So that's removed as a statutory body, replaced by a new DHSC-run patient voice function, yet to obviously be determined. We have, through our revised structure, tried to ensure that we have actually got capacity to make sure that this is embedded in the way that we do business day in, day out. Do you want to move on? One of the key areas was really around national oversight architecture. So at the moment, obviously NHS England oversees ICBs and providers as one of our regulators, with CQC being another. And that's via the oversight framework. Same true for providers. The Secretary of State has indirect influence, and that's through the workings of NHS England rather than directly with providers or with ICBs. But after the bill, if it comes into law as it is set out at the moment, with NHS England removed, DHSC takes on that national oversight, responsible for performance, finance, data standards, etc., etc. There is a lot about the personal direction of Secretary of State in the bill. Want to move on? So specifically in terms of oversight and regulation of ICBs, confirmed as strategic commissioners, our responsibilities are, as we assumed in terms of being clear. Some view that autonomy reduced due to stronger ministerial direction, which includes the ministerial powers, as I say, Secretary of State, in terms of direction to or direct intervention with ICBs. So for us, stronger accountability, if you like, directly to DHSC, but obviously we've got to see how the new NHS operating model via the regions actually plays out, because that's the missing piece of the architecture at this moment in time. So this is what the bill implies. How it will work in practice, we'll have to wait and see in terms of the this coming into law, and secondly, the operating framework for NHS England and our relationship with region, which in turn is obviously a reset of their relationship in terms of DHSC. Do you want to move on? Similar considerations for providers. With the same, obviously, regulatory bodies, but changes in those. Do you want to move on? So for completeness, there's just a diagram there that I'm not sure whether it helps or otherwise, pre and post bill in terms of ICBs and providers. Do you want to just move on? So obviously, we're getting lots of analysis now from various parties who have had the opportunity to take the technical bit out and do those comparisons across various health acts and things. So the King's Fund view the opportunity, if you like, of a single patient record offering in terms of better care coordination, but the other benefit around the clearer local accountability. And my interpretation of that is around our role around designing services around based on population health. Risks from a strategic perspective, there might be a view of over-centralisation of power in DHSC, risk around weaker patient voice with Health Watch going, and insufficient focus on prevention unless backed by investment and cultural change. I think for us, that's actually key. We are, we've got a lot of focus around prevention. So we should be able to mitigate that risk, but it's interesting that it comes through really in terms of a risk across the bill. And then there's just that summary slide, which you can read for yourselves. I just want to list a couple of things that aren't in this high level summary that we can up later if anybody wants to discuss this further. The first is around changes to board membership for integrated care boards in recognition of our changing role as strategic commissioners. So our partner arrangements and therefore future constitution changes alongside that. Reinforcement of the future role, however, for mayoral combined authorities in relation to ICBs. We've already picked up really the direction of or direct intervention into ICBs of Secretary of State. There is an element in relation to the independent sector and Secretary of State discretion regarding the level playing field considerations with NHS provision. And the final thing I have to say, unless it's buried really, really deep and my inability to cross-reference to other health acts, etc., there are no changes to the statutory responsibilities of ICBs in relation to safeguarding, SEND, CHC, children's continuing care, all those things that were trailed in the model ICB blueprint that ICBs would not have to be doing in the future, and therefore our funding was cut because we wouldn't be having to do those things. There is no legislative change that I can identify related to those, which obviously poses a challenge from the start.
Good job, we put them back in then.
Good job we put them back in.
Yeah.
As far as we knew, I suppose we need to see what changes come. Yeah.
Yeah. So that's and you'll find online various different organisations giving an interpretation. I think that's as much as we know from the reference to the King's Speech and the draft bill, which now enters parliamentary process, and we're about to kind of go through summer recess at some point. So there is a long passage to go with various readings and going up to the Lords and stuff. But actually, that is the direction of travel. None of it very much a surprise. I think it's been trailblazed kind of elsewhere. And certainly some of this is about the recognition. Jane's going to talk in a minute about our own work around transition. I'm very conscious that at the moment, NHS England, there's a plan for the abolition of NHS England. And actually, there's an existing kind of consultation process going on around what that looks like at region as well, new relationships and stuff like that. So actually very much it's interesting to see this written down. What it looks like at the end of this process, I think Michelle's right, is that there will be debates about various bits of it. And I would certainly be anticipating a strong patient voice lobby around the abolition of Health Watch. And I kind of think for us as an organisation, you know, patient voice and our co-production is very at the heart of what we do. It doesn't take away the independence that Health Watch brings from the people that don't talk to us. And I think we do need to think collectively about how we might want to think about that as a system, as a group of partners kind of moving forward. So were there any immediate questions? And this will flow through, I think we get through to the second part as well. Jo?
It's just a clarity question. As a still allowed to be newbie.
For this month, yeah.
1 more month, just today. So it just, in what capacity do people within the ICB generally have to influence and consult over all the bill as it passes through Parliament? So we have lots of people on lots of groups is the question I'm asking.
So that's a really interesting question because this is not a consultation. This is a bill before Parliament. So it's Parliament and ultimately then the House of Lords who will get to debate aspects of the bill. So I think the only areas of influence are through the political infrastructure MPs. Yeah,
but we don't have any other than through the chair, through the various MP relationships that you have, any other capacity then to sway.
I wouldn't necessarily see it as our role through our meetings with MPs to actually do any sort of feedback on the health bill. No.
Thank you.
I think on an individual basis, people can express concern. I think very much national organisations will have a view of some of this stuff, and I think certainly I'd anticipate Health Watch England being able to coordinate a health watch response around something. I think very much this is around the starting place, and actually there are bits of it which I think are really good and really helpful, and there are bits of it I'm not quite sure I quite understand what it means, or the thinking needs to be more developed. But I think very much this is direction of travel. It's been signalled already. Where it gets to and how it gets tweaked and changed at the last minute, and what finally comes out the other end in front of the King to sign, I think we don't know at this stage. Michelle.
Yeah, no, it's a really good question, and it's really difficult because we try to be apolitical, much as we possibly can be, but obviously we do have links into MPs. So sometimes MPs ask, so we have to give an obviously open view in relationship to it. But just say that none of this is new, really. I mean, a lot of it came out of the we started with Darcy in the review, and just is broken, and then obviously we worked through a lot of it in that 10-year plan. So over the last sort of year, most of us, I would say, from a senior point of view, have been in some sort of think tank working group, discussion group in relation to trying to shape how it looks now.
Okay.
So that's why there's no real surprises in there. I think for me, and both the ICB and our organisations, that how do we look at the detail of that and see what the implications are, so that to shape, because this is the sort of the architecture really. So how do we then continue to, through our various groups, shape and influence some of that detail? We won't go into the bill, but it will be the operational piece of the bill once it's gone through and been changed and amended. But it's a really good question, but sometimes it's frustrating. But we've been sort of working up to this point for a long time with obviously the ICB structure and various other things.
I think that's really fair. I think some of this is about also redefining relationships, and it's about the new relationship we have with a reformed region, which is a DHSC region rather than an HSC with different functions. So it is all about shifting what we have. It's a kaleidoscope moment where you change the picture and it looks a bit different. Dean, I'll let you have the final words on the health bill.
I was just going to say, for the benefit of Joe, that we've got passage of a bill through Parliament, that you do get organisations like the NHS Alliance, etc., that will provide briefings to the MPs on committees to ask questions on behalf of members that will pull out some of the points. So it's a more collective sort of approach to things. And then likewise, when it goes to the Lords, there'll be similar briefings for the Lords.
Thanks, Dina. And I suppose that was the question really. Is there anybody in the ICB in any of those groups? And do we have a sway on it? I appreciate that we have all the way through it. Thank you.
Okay, so Jane, we're going to move on to you. So you're going to give us, so we're going to come back to this in more detail in the private session later, but I suppose this is just the update to the board on where we're up to with ICB transition, which of course is on the fringes of everything and was kick-started by some of the things that are in that health modernisation bill.
It was, A couple of things to say before I just give you the update. One is you're right that we will have opportunity to discuss it further later, and also for the non-executive directors that are still classed as new, we have a session tomorrow to take through the history of this. We are recording it, so for those of you that aren't able to make it, we'll give you the recording so you can hear it and answer any questions you've got on the back of it. So that'll give you more of the background. For the people that are going through the change, it's still very uncertain, but we've got a lot more certainty for a lot more people. I think it would be fair to say. And for the HR teams, communication teams, particularly finance teams, the volume of work that goes into this, every time I speak about it, I just have to say thank you to those people, because we won't be able to get through this with that amount of work. To remind you, there are 3 stages to our organisational change. We are, and will definitely by the end of this week, have fully completed stage 1. And that had people that were slotted into roles, people that were ring fenced and then went through competitive process and then were successful in roles. We've got 3 final interviews this week, and then that is fully concluded, delayed slightly just because of annual leave and other things. We also, for our stage 2, split it into 2 sections. So we've got a stage 2A and a stage 2B. The 2A was because we couldn't easily match people at stage 1 in certain parts of our organisation. And we've begun the stage 2A. So we've already had the most senior roles that have been appointed to. That happened last week. The rest of 2A begins next week. And so we'll continue to progress through that. Stage 2A did allow us, so voluntary redundancy is a key part of this as well.
And through stage one, we actually approved 84 voluntary redundancies. Stage 2A allows us to approve another 49 voluntary redundancies. Those people are in the process of signing their settlement agreements and confirming their leaving dates. But we already, for those with short notice, have people leaving us imminently. On the back of that, we've set up on our intranet a leave us wall so people can actually send good wishes to their colleagues that are leaving and just connect in a more humane way, really, around that leaving process. We've also this week commenced the beginnings of stage 2B, which is the executive, the most senior roles, because there is nobody else left now that could consider that a suitable alternative. We know exactly who they are. The interviews for that, I think, will be in a couple of weeks' time. So 2A will be taking place in early June, the rest of it, other than the senior ones we've already done. And 2B will begin from early June, including the more senior ones that we've got. So that's the org change part of it itself. Awful lot of activity going on within that. At the end of April, though, we set up what we're calling our collaborative leadership group, and that is people that were already either slotted in and therefore appointed in the senior roles that reported through to executive directors, or people that were covering those roles while we were going through the organisational change process. And that's been really helpful because it's allowing us to focus on setting up and standing up our future organisation. So in some cases, some of those teams have got quite full slotting or ring fencing that's already concluded. It might not be 100%, but it's certainly a large majority of those people that are already in position. And there's a whole spectrum right through to where there's hardly any in some areas, and they won't come till stage 2B or stage 3, which is when it's opened up fully. So we've already got some areas of the organisation that are now standing up, which is really positive because that helps us focus on what that's going to look like in the future. But we've also got an awful lot of people still here working their notice through voluntary redundancy. So it is complex and difficult work, I think, is how I would explain it, both from the detail of what they're covering, but also the human elements of how people feel in those situations, and making sure that we continue to value the work that people are doing and have done, and that we honour the legacy that people are leaving as we change into that new world. So I know it's verbal, and there's quite a lot in there, but that's more or less where we are, I think I would say.
Yeah, and we can come on to more detail later on. I think, what I would say before I bring Bev in is I think, there is, I appreciate the sensitivity in terms of staff at the moment for those who know what the outcome is, those who are awaiting an outcome, and those who are working notice. So I kind of think it has been a really challenging time. It's over a year since that first announcement.
It is, yeah.
But actually we are continuing, I think, to deliver in terms of the legacy work, but also the energy that is going into that future ICB and everything that we kind of touched on today. And I think I know we're all very appreciative of that, but it feels as though we are making progress. And at times I know I find it frustratingly slow. But I do feel like we are observing process in the right way. And I think we committed at the start of this. I remember you and I talked about doing this once and well. And I kind of feel we are doing this once and we are doing it very well. However frustrated I feel at times. So we're just going to take in, so we're going to take in Joe and Sue, and we will have a chance to go around it again later on. So Joe.
Just very quickly, thank you for the update, Jane. And it was really heartening to hear that you're considering the leave of war and just really helping people with that process, which is great. Just to help the people that stay, though, understand the new roles, how are you handling communications about, this person has been slotted into this role and their new accountabilities are X?
Yeah. That is definitely a continuing work in progress, but there's probably a couple of things to say around it. So now that we were getting to the end of stage 1, we have released, it's called Appendix 3 in our organisational change document, but it's all the structures highlighted with where people are appointed and now with the names of the people that are appointed into those roles. So I think that's quite important because when we've done previous org change, people have got quite frustrated that you know the role, but who's the person that's doing that role and how do I get in touch with them? So that was released last week. And when we began all of this way back a year ago, we did say that we would err on the side of over communicating rather than under communicating. That's been challenging through the org change process, was less challenging running up to it.
Yeah.
Once you're in it and you're in process, it became more challenging in terms of some of that communication. The CLG group, the collaborative leadership group, the leaders that are in that are working really closely locally with their people around what does that mean then in your role, which bits of it are standing up. And as we get to that being more comprehensive, we'll have a whole organisational development programme that comes on the back of that, because it isn't just the task elements of what you're doing, it's the behaviours, how you connect and engage, the way you are with each other. We've got some really strong values that we developed with our people, and we'll go back round that to say, you know, in our new organisation, are they still valuable and right? But we're not at that point yet, and we'll have less people to do that, I think. Particularly in the areas where you would ordinarily have leadership for that won't exist in the future model. Great. Thank you, Jane.
And there's that much wider piece of work as well, which I think we've touched on before here, which is around the whole OD programme that now to sit around the new organisation, including the board, as to how we do that. So I missed Bev, so I'm going to take Bev, Sue, and then Michelle, and then we're going to do the NHS app. Bev.
Thank you. So I don't feel like I'm new, Ned. I think I've been here forever.
Old Ned.
Perfectly honest.
Transition committee.
It's because of the transition committee, certainly for the last 6 weeks, the last 3 meetings. The last one was just yesterday. For me, coming in from the outside, I haven't been through significant organisational change through 39 years of working in the National Health Service. It's been right from the beginning for me, very clear, very focused work, incredibly challenging for Jane and others around the table. And we mustn't forget that they are still part of this process. They are still involved in that. But the way they've conducted themselves for me has been absolutely exemplary. And all the staff have been affected, and we've talked through stories and the care and kindness and compassion that's been attached to that has been absolutely admirable. So just really wanted to put on record and assure other non-executive director colleagues and members of the public, because we're in a public board meeting, that it's been incredibly well led. And there has been significant challenge from the chair and the chief executive, which you've dealt with. Ones have dealt with very well. Thank you. Feedback's a gift.
Yeah, challenging the right. Sorry, kind of thing. Yeah, I think that's our job. Have a word in a minute, Ms. Riley. Anyway, Sue.
Thank you. On a similar vein, on a personal level, I've had contact with a number of colleagues who are taking voluntary redundancy. I have to say they have been uber professional. They have been very open about their position and been really clear what they can and can't do, which makes it easier that you're not making assumptions.
Yeah.
So on a very personal level, I feel I've been really well supported by some of those individuals that actually are going. And I think that that's probably testimony to the fact that they have felt that they've been treated in a kind way.
That's really important to hear. Thank you. Thank you, Sue. Final words on this one, Michelle.
Yeah, I was going to really say what's already been said, really, but from a system point of view, because I'm not inside the organisation, and to say that everybody that not just our organisation, but other organisations have had the interactions. It's been very positive, very professional. There's been no undermining or anything. And the other thing as well is that we are still continuing to pick up pieces of work that obviously people thought might just stop or. I know it was for that transition bit, but we've also had some staff that have accessed. If you remember, I've offered many times from an organisation point of support staff that needed that psychological support, and we've done that because obviously a lot of these staff have been through that organisation body in really quick succession because they have this CCG point of view, so that brings up all that pain, for want of a better description. So we have had some staff that have accessed it. So just to reassure you that buffer has gone out and has been taken up. But just from a system-wide point of view, absolutely professional, absolutely carrying on with things, and we've not found very much gaping holes at the moment. I think that's commendable from the way the ICB and the staff within it have been working. And it's typical NHS staff, isn't it? Because they just fab out the room, but they have been particularly.
That's really good to hear. Thank you.
And different, because obviously I interact with some other ICBs that you can there are different sides.
Yeah, we are. Yeah, there is. It is happening all over the place. And I kind of think, you know, there is a lot of energy as to how people have approached this, because there's no one set way to do it. I think for me, my reflection after, you know, the Clare Fuller visit was that the fact that we decided to redesign an organisation based on what we have to do in the future was absolutely validated by that feedback we had. It was the right thing to do. It was all the jigsaw pieces kind of in the right place. So okay, well, we'll come on to some more detail around that in the second part of the meeting. But I think that feedback is really appreciated. So Anya, we're going to talk NHS app.
Yes, thank you, Chair. As colleagues know, we feel it's really important to bring our Voice of the Lived Experience report to our public board meetings, and they are usually around key themes or points of interest that are being raised to us through our involvement. This time it's the spotlight on the NHS app, which is very pertinent. We've already touched on it a couple of times in other items today. And I think it's really helpful actually to use this as an example of the way we currently work, but how we want to work in the future. Because from a more qualitative engagement perspective, we already have some insight around use and experience of the NHS app. Our digital team then had got some really helpful statistics that are in the pack that you've got around the quantitative data around use. And I think there's a real risk sometimes that we can just interpret what we think quantitative data means and make assumptions on that. But actually, with the teams working together, they wanted to test, actually, is this as positive as it looks in terms of the quantitative data, and how do we continue to build and learn on what we think this picture is telling us. So that was the premise of this particular piece of work. So I'm not going to go through the report verbatim. There is a short film which we will share in a minute. I just want to go through some of the key points. So as you can see from the report, there is a strong uptake and clear benefits resulting from that uptake. So 60%, 67% should I say, of GP patients aged 13 plus are registered with the app, and we have over 1 million users locally. In 2025, there was significant operational impact, particularly with 117,000 appointments being managed through the app, and around 3 million repeat prescriptions processed through the app, which is really significant. And clearly that will deliver substantial time savings for patients, particularly in reducing waiting and travel times. And we know that that is an issue that they have. And for particularly from our primary care staff in terms of that administrative time reduction. And crucially, patients are valuing the benefits of the app, particularly they see at present the strongest benefits being around ordering repeat prescriptions and accessing test results and medical records. And they recognise it as improving in terms of the convenience, speed and access to information and the ability for patients to self-manage their care. They can see the opportunity that this presents. There were, however, some key challenges from the lived experience of our users of the app that were identified. And we know some of this, but it's really helpful to have it again as that live insight. So there is an inconsistent offer across our GP practices. So as an example, appointment booking is not universally enabled, so not everybody can access that feature, even though they perhaps want to. There is variable user experience. So some people finding the app, you find it very easy. Others find it complex or difficult to navigate. There are gaps in functionality and content. So as an example, some are saying there is limited access to hospital records and historic data. Digital exclusion, as we know, remains a risk, and there is lower confidence amongst older age groups and some particular communities. And there are practical barriers. So some users are telling us about delays in registration, or some people having frustrations in terms of logging and security issues. But absolutely, the data is telling us that the core usage remains around prescriptions, test results and records, which accounts for over 70% of the usage, and lower use of appointment bookings. Many people not understanding that you can access NHS 111 via the app and the advice function. So it's really highlighting there is a lot of untapped potential for us beyond the current functions that are being used. We have articulated that there are actions already underway, and some have been underway for some time, and that includes targeted digital inclusion activity, and a lot of this has been led and continues to be led by our VCSE sector, a real focus on some of our more underserved and seldom heard groups in terms of improving access and confidence, and continued work to increase uptake and usage, again supported by the local insight. And just some key recommendations, and of course I'll say, and it links to the point you raised before actually, Jo. Our digital lead is very embedded in a lot of the national work, so we'll also be feeding this in. But absolutely, opportunity for increased use of notifications. I'm sure for the apps we all use, we will use notifications where it's relevant to improve engagement and reduce missed interactions and cost. To drive the consistency of offer across practices, to continue to improve user experience and guidance, to reduce the registration delays, which is a cause of frustration, and to scale some of those digital inclusion efforts. So that's just a summary, which I hope is helpful. And Emma, before we open it up to any comments, would you mind just playing the short film? Thank you.
Thank you. So, any thoughts about that? I mean, the app thing, it's recently been updated, hasn't it? Because when I used to order a repeat prescription, I used to have to wait for a text message from the pharmacy. And then suddenly I got really excited. I got a message on the NHS app and I thought, oh, what am I getting? And it told me my prescription was ready. And I thought, actually, there's a real linking up there. It was a gap before. And I really quite liked it. It's quite nice to get a message that wasn't about a lift being out of order. So that was quite nice. But so I'm going to take Nigel and Zoe, and I do say want to come to the point around, is everybody using it, that consistency? Because I think that's clearly feedback that people are enthusiastic to use it and get frustrated when some people aren't, some people aren't. So I'll give you time to think about the response to that one before I come to you, and I'll go to the other doctor in the room. Nigel.
Yeah, it's just picking up on something that Anya said, just to pull out the importance of the notification issue, because we do, or the NHS does pay for SMS costs.
And it's very expensive, isn't it?
It's expensive. So therefore, with notifications being enabled on the app, that is a cost saving, and therefore that resource could be reinvested elsewhere. So it's just a sort of a plea for people to understand why it's so important to have those notifications through the NHS app.
Yeah. And if we get people registered to that point, that feedback, isn't it, that's about, it's a bit scary to get started. And I'll come on to that in a minute, because I think we've done some really good stuff in Humber and Authority around that. Zoe, I was trying to think.
Thanks.
I'm expecting a superb response.
Right, okay. So none of that surprises me from a primary care point of view, none of that feedback, because we hear it from patients regularly. As ever, it's never as straightforward as it might seem. So a couple of things I would say. So firstly, there are a number of different apps that patients can use to access their GP record online, order medication, see their notes, do a number of things. Patients, in my experience, vote with their feet. If they try the NHS app once and it doesn't work for them, they don't try it again. And often when either the clinical system's own app or another app gives them the access they need, they will use that. So one of the issues we have with the data from an ICB perspective is we know how many people are using the NHS app. We don't know how many people are using the clinical system's own app.
Yeah.
So they may still be digitally enabled, but they're not using the NHS one. So that's the first problem. The second problem is that this is an add-on, and it's a very good add-on when it works, but it is something extra for us to communicate with patients, and also to make sure staff are trained to communicate and to show them how to use it. And when it works well, we've seen examples where, for instance, the N3I team are based in a surgery and are showing people how to use it and download it. But given that a lot of patient access is remote, actually having someone in your house to show you how to use it doesn't happen. So there's something about we're asking our reception staff often, when it's busy, when there's a point of contact, when a patient needs something else doing, to then be having this conversation as well. And we need to recognise that and put some resource into that. But we also need to look at the functionality from the other end, because one of the reasons why some practices may not support this as much is because actually the functionality at the practice end, the patient makes the request, great, it's sometimes clunky at their end. And it's actually harder when the request comes through the NHS app to then workflow and process than it is to do it through other means. So some of those are not within our control because this is national. Some of them are within our control, and we can work closely with our colleagues like John Mitchell, like the N3I team, and with our patient groups to really try and focus in on those.
I think that's a really good point. And I want to throw a spotlight, I think, on the work Gary Sainty, our BCS lead, kind of led about 2 years ago now, which was around using the opportunity we had with BCS groups to actually sit and take the time with people attending their lunch club or their support group to get them all registered on the app. And actually the quickest learners in the world. And actually that was about taking the time. And forgive me, some of it was about instructions that weren't the NHS drafted instructions. They were press this, no, don't press that. Now you've deleted this, now you've deleted that. So there is something around. We've demonstrated, and I think our take-up, wasn't it, Anya? Our take-up of the app based on some of those interventions was really significant, particularly, I think, in rural areas. We had a conversation last time, didn't we, about access to services in rural areas. Digital and how we enable people to use digital properly is really, really important. And actually, the ability to order prescription at 3 a.m. on an app works for me. Don't even think about what I'm doing at 3 a.m. on an app, but that's absolutely fine. Jane, and then Jane.
So my question is for you, Zoe, also. So where's the driver? Does it sit within our accountabilities of the ICB, or is it NHS England to ensure that primary care settings are directing people to the app rather than to their own back office systems?
whatever they.
So it's not their own systems. It's the providers of the clinical software. So it's not your practice's alternative or the NHS app. They exist, all of them out there for patients. There is no direct requirement on primary care.
Yeah.
There's no contractual lever that can be used. So really what it's relying on is getting rid of the obstacles and working alongside them to address when there are issues. I think there is definitely an inherited problem where when the NHS app originally launched, it wasn't brilliant. People tried it, it didn't work, and they haven't gone back to it. So there's something for me about the issue Nigel raised around the costs linked to it, and also listening directly to feedback, because often it is our reception staff or our GPs or our community pharmacists who are there with a patient saying, I've tried to do this on the app and it doesn't work. And we don't really have a feedback mechanism to listen to those colleagues that get that day-to-day stuff. So I think I'm sure it's something we can improve, but I think we need to be looking at it from a working in partnership rather than this is something that needs to be done.
And I think there's some clear linkages with neighbourhood health there, aren't there? Some clear linkages in terms of if this is about prevention and managing services in communities, then the app becomes really valuable in terms of doing that. It's not the only way, but actually there are some things that you will still need to contact the practice for. But I think what it starts to do is to take away some of the stuff that probably means that there's a queue of 75 people waiting to speak to the practice. I think, and it will continue to develop, and that commitment I think is there, isn't it? And the health will continue to develop, and certainly a plan to develop the app as being that key point of contact. Anya, over to you. Then I'm going to reorder the agenda and take Nolan. I miss Jane. Jane.
You did miss me. It follows on from what you've been saying, I think, Zoe, in that not all practices provide a consistent approach to what they have in the NHS app. So, if a patient goes on and they can't book an appointment, for example, because that functionality isn't switched on in the practice, they'll just stop using the app, really, or use what they were used to in terms of those other clinical areas. So trying to get practices to a point where there's a core offer that patients can connect with that allows them to have that digital ability to manage their life and contact, I think is really important.
Yeah, and I think that's part of the neighbourhood health stuff, because we talk about core officers of neighbourhood health. I think we've got the opportunity there collectively through neighbourhood health to start to look at where each practice is and actually the ambition for where the practice kind of wants to be. Because I think it is about working with, because I don't think it's about imposing, it's about saying what's the opportunity we have and actually how does that benefit patients and benefit the way that the system currently works. I think that's very important.
It might be helpful, so just to come back, I don't know, but I would guess we do have that data about what functionality is enabled by each practice, and that would be really useful to go through.
And if not, it's data we should pull together,
because then we can target conversations.
Yeah, exactly. Anya, final word before we go. I'm going to move the agenda and go to Nolan's sustainability.
Thank you. It was just the wider associated point that was touched on in the comments from Zoe and Joe, and that is around, I think there's a learning for the NHS around how behaviour change is supported, which is what this is, because you've articulated, it's almost sometimes we have this view of, we'll develop an app and just expect people to use it, whereas we know we absolutely have to put in the resource to support people to make that change. And crucially, their experience of doing things in a different way has to be not just positive, but better than their other experience for them to make that behavioural change. And it's the same, we've seen it with things like Pharmacy First, etc. We can't just expect that people will switch to it. So I think there is a piece for us to just recognise that if we want to encourage that behavioural shift, we have to, as the NHS, resource it. And I know colleagues get fed up with me talking about some of the examples from other sectors, but when you look at the move in banking to online banking now, and again, our residents are 6 times more likely to use online banking for obviously their banking services than they are for using online tools in their health services. When you look at supermarkets moving to the self-service checkout, if we can think back to in the day when they started that and how many people were there to encourage you and support you and build your confidence, and we don't tend to put that same level of resource in to support the shift. So it's just the wider learning point. Thanks, Chair.
Definitely. Thank you. And that's really helpful. I think it fits into the context of everything that we've talked about today already. So super. So Nolan, are you still with us? Can we digitally enable Nolan?
And just before Nolan comes in, I just had a little preamble to the.
Yeah, let's just get Nolan back first. Nolan's.
Yeah, there's this.
Oh, there you are, Nolan. I was worried that we'd lost you or we'd kind of deleted you or something. But so Des is going to do a preamble, Nolan. So you've still got time to work out what you're going to say. Des.
I just wanted to mention just a couple of things. Obviously, this is a standing item we bring to the board twice a year, just to give a very brief update on where we are with our green plan or our sustainability plan. And the points to note are just that through the audit committee, we take regular updates in respect to the specific technical criteria. So this report isn't around that, so because that is managed through the audit committee in terms of what we report in the annual report. And the other thing, I suppose, just to bear in mind is as we move forward as a strategic commissioner, we will have to develop our strategy around commissioning for sustainability. That will be one of the key objectives that we have, and that will flow through the strategic commissioning committee. So, to our points earlier around terms of reference and committees, we just need to think about where this sits and how we bring that forward through a contracting lens and report that out to the board as well. So those are just the 2 points I wanted to make ahead of what Nolan had to say.
That's really helpful. And green plan, remind me, Nolan, green plan was it was a hokey cokey thing, wasn't it? It was in, out, in, out.
It's in.
It finally kind of came back in. And I kind of think the board, almost a year ago now, kind of signed off the green plan. And actually, I think you did a really good job in talking to us around what that meant. This is that regular kind of update. And I'm pleased that Des has talked about the technical stuff sitting with audit. Thank you, Katrina, for having the technical stuff. This is the broad overview of the assurance for the board around the green plan. And I think, like Des has touched on, I think the requirement to look at sustainability throughout all of our future kind of commissioning is there. And I think this is kind of, I suppose, demonstrated to the board, and in particular, the people who are new for today only. This is kind of where we've got to in terms of stuff, and a lot of work has gone on behind the scenes. So, to preempt that, thank you, Nolan, for everything you've done to move this one forward. So over to you.
Okay, thank you, Chair. And I think it's probably worth pointing out that the green plan covers a period 2025, which is when it was refreshed, as you just mentioned, through to 2028. And what I'm about to briefly run through relates to the performance so far to date. It's an overview with regard to our performance on all sustainability and climate related matters across the system, across the whole of Humber and North Yorkshire. And in summary, our progress across Humber North Yorkshire is good, and we continue to strengthen our performance, particularly around governance, strategy, risk management, and metrics and targets. Our green plan sets a very clear direction for this, and it's aligned with NHSE net zero commitments, Yorkshire and Humber Climate Change Commission principles, and significantly the national requirements that are set out in the DHSC's Group Accounting Manual and requirements for reporting against the Task Force on Climate-related Financial Disclosures. Our action has and continues to be structured around 3 long-term aims, which are reducing greenhouse gas emissions, adaptation and adapting to the impacts of climate change, and healthier lives and well-being of our people across all populations within Humber and North Yorkshire. If we can move on to the next slide, please. Work is centred and continues to be centred around 12 key priority areas, and detailed planned action across each of those 12 areas is set out in the green plan itself, which is available on the HNY website. And that covers the period, as I already mentioned, 2025 through to 2028. Generally, across the last 6 months, bearing in mind this is a biannual update, and as I've already briefly mentioned, we've strengthened our governance and leadership arrangements to continue to underpin good delivery with clear board oversight, as we see through today's meeting, and also detailed oversight through the Finance Committee, as Des has already mentioned. System-wide arrangements have been strengthened to reduce the climate and environmental impact targeted to lower carbon footprint, and continued improvements continue to take place across estates and transport-related areas, particularly focused around decarbonisation with investment in energy efficiency measures. Partners across whole of Humber North Yorkshire, including both commissioners and providers, are working collaboratively to harness digital transformation. Interesting, as the previous item was discussing the app and the impacts that can have in terms of reducing the need for people to travel and be physically present to get the support that they need. And across all 12 green plan focus areas, we monitor performance using the Green Air NHS dashboard, which provides a very clear and transparent view of performance and areas for further improvement. If we move on to the next slide. Specifically over the last 6 months, highlights in the area of primary care have been focused on improvements around asthma treatment and reducing the greenhouse gas emissions associated with that, relevant to 2019-2020 benchmark. Our community and social enterprises across HNY have continued to improve performance, particularly in the areas of biodiversity. And there's been significant trust-related action around estate and infrastructure investment to reduce the carbon footprint, both of estate and infrastructure, and also clinical practice. If we move on to the next slide. Our understanding and management of climate risk has been strengthened, and that's particularly seen through a shift towards full compliance in the area of climate-related financial disclosures. We've strengthened our understanding of climate risks, and these are now fully recorded in sustainability risk registers, particularly with regard to adaptation. Work's underway to improve our preparedness, with planning underway on a severe weather event, which is due to take place later this year, and that will raise awareness and also initiate action across the system to ensure that we're prepared for the effects of climate change, particularly thinking about extreme weather events, both hot weather and flooding. And very specifically, environmental performance and resilience to climate change is a specific criteria that we now apply in estate-related investment decision making, making sure that as we invest in our estate, we invest in a way which is sustainable for the future. And then final slide, please. So this slide sets out our performance with regard to our disclosures relating to the Task Force for Climate-related Financial Disclosures, a key part of the Group Accounting Manual that I mentioned earlier. And we've seen a significant shift towards full compliance over this last 6 months. We now have 7 areas which are fully compliant, 4 areas which are partially compliant, and we have no areas which are indicating non-compliance. And further action is planned to shift this towards full compliance, overseen by the Audit Committee, as it's previously mentioned, again, in terms of the direct and detailed oversight that that committee provides. And that concludes the biannual update on sustainability matters, particularly relating to our Green Plan and Task Force on Climate-related Financial Disclosures.
Well done. Nice to see a risk register with no harms. So, any questions for Nolan? So this is about the board being assured that we are meeting our compliance with the requirements in terms of the sustainability of the Green Plan. People do want to see the Green Plan. The Green Plan is on the website. I think we have to publish it. And actually there is considerable progress in there. And I think Teresa and I, we went to Catterick, didn't we? And Catterick's kind of referenced on that. And what is really amazing, and I know that Catterick is a new build, but the sustainability that is kind of threaded through that building in terms of its power, the layout, how it's been built, is actually, it's so impressive to see in action that the real thought that goes into constructing a building and around that impact that building has on climate is really amazing. So we have said that we will go to Catterick together and have a look at that. I'm really keen that we share that with the board. And actually, it is so impressive, but also we are doing huge amounts of work as well, I think, Nolan, in terms of our existing estate, but also in the way that we work, which is, I think, exactly what this is about. This is about how enhancing what we do, not doing lots of new things just because we want to turn things from red to green. I think it's a really good piece of work. Any questions for Nolan on this one? Katrina?
So, yeah, it was just on your point there. It's not just about turning red to green. Yes. I'm really interested in that cultural piece. So there's obviously the plan and doing what we've committed to doing, but how are we making sure that we're changing the culture so they're not just doing the plan, but actually where there's opportunities at no additional cost or compromise, that we're not limiting people by the plan, but doing what's possible.
Is that, I mean, Des Nolan, how are we doing that? Because actually there is something around the plan is the plan, but I think what has been identified are actions that are on top of the plan, isn't it?
Yeah, I'll let them come in and then I'll
say. Right, Nolan, Des has skillfully bowled that one to you.
I think that's a really good point, and I think significantly the Green Plan effectively sets out the minimum standard really that we should be seeking to achieve. It's not a constraining factor, it's not a ceiling in terms of performance or expectation. All providers ultimately are accountable for their own actions with regard to green plan activity and sustainability performance. And that's something, there's a real strength in that because it allows innovation to come through. And that's a key part, again, of the green plan, which is both digital innovation and innovation more generally. And we have communities of practice which are supported by NHS England, Greener NHS, that actually help spread that good practice and also provide some peer challenge within that as well. Which is something that's subject to our future arrangements as a strategic commissioner, as Des has mentioned, in terms of as our accountabilities change, together with those of region and indeed providers. We need to be really mindful that we don't lose that focus of really sort of challenging each other and driving performance forward, as opposed to just ticking a series of boxes. I think something, again, that you just highlighted around it, it's not just about a series of actions and ticking boxes. It really is a cultural thing. And some of that relates to not just what we do. I think very often we can think about environmental performance and sustainability as renewable energy and buildings. It is that, but it's much more than that. It relates to clinical practice, the decisions that we make about prescribing, how we manage repeat prescribing and such like. And also significantly, again, as I've mentioned, going back to buildings, how we actually invest in our buildings and our estate. So we make sure that we're investing in spaces that are in the right places 50 and 100 years from now. So we're not building or investing in spaces that are highly susceptible to flooding or shifting services towards buildings where there's a significant risk of overheating.
Yeah. And we'll come back to buildings, so I'll see you later.
Indeed.
Very comprehensive answer, thank you.
Yeah, just Nancy.
So just really briefly, there's a couple of things in there for me and that we've touched on already, which one of is the strategy we would need to bring through strategic commissioning committee about how we commission and
where it
on all those things that Nolan just said. But also there's something internally for us about that way we work, and we're fully expecting, we know that Nolan will have a seat around the table in those programme of care commissioning conversations, and that brings, I suppose, a lens for our own teams to make sure that we are following up with that strategy and actually embedding that strategy in the way that we work as well. So those are the sort of practical kind of responses to that question as well.
And I think the opportunity we have with future contracting and commissioning is massive in this area. So, see, final words on Green Plan.
Yeah, it's following on in some ways from that commissioning comment, because in another life, one of the challenges is if we are going to reinvest in our local communities and voluntary sector agencies to deliver closer to our residents, some of the criteria that relates to this can be inhibiting for them, because their ability to comply when they're small organisations is significantly challenged. So I think we've got to be really mindful that whilst we have an ambition to have it as part of our commissioning intentions, there has to be a flexibility when we're starting to commission smaller organisations that are more perfectly formed maybe to deliver at that neighbourhood level.
I think it's a really important point. And I think there is something about, as we move into that new commissioning landscape, there's an issue of proportionality about actually not excluding, but think about how we include, but also how we get the outcome in a different way for some people. I think that's a really important point to bear in mind. Is there anything anyone else wants to say about Green Plan? Because Nolan needs to go and prepare for his next visit with us later on. So in terms of this, we will sit Des.
So sorry, Chair. Just to Sue's point as well, I think one of the
Des is thinking now.
We will need to be mindful of is there aren't actually national funding streams for some of these things. Exactly to that point, Sue. So it's also bringing in that sort of what is the art of the possible in terms of accessing and helping our partner organisations access funding that is nationally available as well. Making sure we just maximise all the routes that we have to enabling that. So I think that's a really important point for us to incorporate.
And there's also a link across to research and innovation in this space, isn't there? And I kind of think, particularly Yorkshire and Humber, we have a lot of opportunity around research innovation around the green agenda, which I think, we have an opportunity to maximise as well. So we will see you later, Nolan. So in terms of this, we will see you in 6 months. Katrina has agreed to take all the technicalities into the audit committee, for which I am incredibly grateful. But we will see you later on today.
Okay, thank you very much.
Thanks, Donna. So go back to the agenda. So we'll just move that around. So we're going to move into, so the next one is your out of area placement. So Michelle is declaring an interest, but Michelle is staying in the room because I think Michelle's got some significant contribution to make with this. This sits with Amanda and Sean. Who is leading this one?
I'm going to pick off quietly.
I mean, the report is there, isn't it?
Yeah.
I mean, we can look at what the highlight is. And then I kind of think this is a really significant kind of piece of work that flows through everything that we've talked about today.
So briefly, Chair, I'll take the paper as read. Purpose of the report is to provide assurance for board members around the oversight of out of area placements. The context of this is that in the medium term planning framework, there is a clear commitment by March 2028 not to have any people who are in out of area placements. There is a caveat to that, and you'll see that in the paper. There are some times when people do need to be placed out of area. An example of that is for safeguarding concerns, if there's gang related activity, etc. So there is a nuance to that. Board members are asked to do three things, just as we pull out some of the information that's around noting the significant work already done by the collaborative. You'll see in the paper that there has been a reduction in out of area placements since April of last year to March this year. Also to ask to note the intent of the ICB to commit to the NHS requirement of working towards having zero inappropriate out of area placements, and then to also note the risks that we will continue to work through in terms of out of area placements as well. So board members are asked to note those three things. I suppose just before I hand over to Sean, it was really just to highlight the quality of area placements and the fact that actually such placements can add significant delays to really trying to mobilise patients to get them in the right environment. And when we talk about delays, we can sometimes be talking about years. This is not weeks or months. This can be very, very long. And that can add to the trauma of individuals who actually already carry a lot of trauma with them from prior experience. So really important commissioning intention in terms of the quality aspects of this work. I'm going to hand over to Sean just to highlight the work.
Yeah, I mean, I think you've covered the main things there. And just to briefly add that clearly this is part and parcel of the work we do with our providers on an ongoing basis. But the trigger for this came from an adverse sequence of events, an independent sector provider in Northampton that received quite a national publicity a few months ago. So we've been particularly asked to make sure we've got a very good place in context of that situation, and this process stems from that. So hopefully the board sure about that perhaps.
And Michelle, coming to you. I mean, anything you want to add? I mean, this is a really significant kind of transformative kind of commitment, isn't it, in terms of outcomes for patients? It does describe within this report why actually there is some exceptions, but actually better outcomes working together to look at reducing the number of out of area patients, and a strong commitment from the ICB and its partners to do that. So, Michelle, anything you wanted to add into this?
Not really. It's obviously that's something that from a collaborative point of view we've been working on for a long time. What we're talking about is inappropriate out of area. There are appropriate, as we alluded to, but for a few, but they should be really, really, really small. We've got different variations across the ICB patch, and that relates both to pathways, but also about service provision and previous investment in relationship to community services. There's also quite a strong relationship to local authority as well, because local authorities do have quite a strong influence on out of areas and that sustainability. So what we have demonstrated by working close together is that we're trying to reduce that variation, but because the collaborative manages with the small and the case managers, when we've been able to make sure that the places are more appropriate, but also we follow them through, because what was happening before was they weren't necessarily followed through. And that's not a comment or criticism of anybody, by the way, this just happened. But because we actually keep a regular review of them, when we can keep an eye on the placement details, the standard of care for placement is, but also if that placement is still appropriate. because what people were doing was going into an out of area bed and then staying there for a long time rather than being repatriated back. And it's not just about the individual, it's about the family as well, and that family unit. So, and that's why we managed to do, because I'm a great believer, as you know, I mean, obviously, apart from being obsessed with culture, it's that quality and finance go together. So if you sort the quality out, the finance follows and vice versa. So because we've looked at that quality piece, we've actually saved some money to be able to reinvest back in. So the numbers are still higher than we would want, and certainly from our organisation, to be honest, but we know we've got plans in relationship to do that. And that's predominantly from an older person's point of view. But when you look at our bed base is one of the lowest in the country, and we're going to keep it like that. We just need to do some things around the side, and we do the intensive care for all of most of the partners in the system anyway. So I think we've got that plan. One of the things I will add, and there's been a lot of talk from the NHSE and Jim's team, particularly around strengthening mental health outcome focused for this year, particularly from a performance point of view. There's going to be quite a lot of intense scrutiny on mental health over the next 6 months. I'm guessing. So one of the things that a few of the CEOs have been looking at is some real targets that we can meet. And one of the things we're looking at is out of areas, and it affects this paper because it says 2028 in the paper. And I think that's quite a long time. I think I was sat around the table, I'll be actually challenging me and the others to say, was 2028 suitable? Because that's an age. I think it's done sooner, but personally. But what we are trying to do is have that as one of the key metrics that are going to be related to mental health trusts, which will be no inappropriate out of area placements by the end of this year. So that'll be 2027. So you may want to set as a stretch target. I can't believe I'm saying this out loud. You may want to set as a stretch target of saying, well, can you get to zero?
You know, I'm going to say straight in the
By 2027. I like a challenge. Those people involved will know that I like a challenge. So that's what I would predominantly say to the ICD all the time.
So there's encouragement for us to change the 8 to a 7. I think
my team will kill me when I go back.
But let's see how that one lands. But I do think from being Zoe, and I think this really does demonstrate the work of a collaborative to kind of look at a local solution to an issue, and very much that new style of working is about how we work alongside each other to say, here's the issue, what's the solution? And I think that comes across really strongly in this. Is it's a shared commitment across providers and the commissioner to say, this is something that we need to look at. What's the opportunity? And I hope Michelle wanted to change the date there. So we need to make sure that's in the minutes.
So can I through the chair that I think that's really important. But obviously, as we're in a transition piece at the moment, where the CEOs are aware of, trees as well, that's why it's so important to keep that, maintain that partnership and that, and that influence from the ICB in order to maintain it. Otherwise, it will affect things like this.
Yes, and I think that's exactly right. I think that's exactly. So Zoe.
It's a question under reflection. So I think my understanding is correct that the out of area placements cost more than in area placements. There's something for me about us making sure that the lens is, as you said, Michelle, the quality lens, not the cost lens. Because yes, it would be great to have a cost saving, but actually we're already spending that money. And if investing that money in our local providers gives us the additional capacity, that should be the focus, not let's save the money and there end up reducing that capacity. So do you feel supported, Michelle, in terms of the focus is on getting people in the right place rather than a cost reduction, or have you got an eye on both of them?
I've got an eye on both of them, I think, but I think what I'm trying to say is that because of the process that we've put in place now, we're doing a lot more. I'm not going to say ensure because it's a really difficult word to say, but we have got a better handle on the quality placements because we follow them up with the care managers. What was happening before is ICB placed them, and this is no criticism at all, and then just placed them and didn't follow them through. So because we've got care managers and case managers that are actually looking at follow the patient, but also to follow that pathway as well. So once that patient is deemed to be suitable, they're either repatriated or discharge. What we also do, we do this specifically in specialist commissioning because our organisation is a commissioner as well from a SpecCom, but we're absolutely fastidious about, and that's because of the collective nature of the partnership we've got. We inspect those quality organisations as well on a very regular basis because we can do that if we've got the power of commissioning intentions to be able to say that we're not happy. So that's what we're trying to work through that system with. But if our our case managers would go in and not be happy, then we would look to repatriate them back. For example, we didn't have a really in Northampton at the time, which is really positive. So I think you're absolutely right. And what we've tried to do is that we have saved a little bit, and then certainly within the Specialist Commissioning Group, and we've reinvested that in the pathway, which has then in turn created more surplus, which we've reinvested as well, and given some back to the system, given some back to NHS England.
Yeah. And I think this is about the assurance as to how we are managing this process and how we are working together to achieve the ambitions. Now, I think it's about being really mindful of the outcomes being the driver, but having an eye on the money as well. I think that's important. So I'm going to take Teresa, then take Sean, and then we're going to move on to the next bit, because I'm very conscious of time, but I've let this go because I think we've probably had the right conversations in the room today that we've needed to have. So
I just wanted to add one thing, which is around actually, it's the focus also needs to be on when people are referred to or considered for referral to an out of area placement, having the appropriate challenge and oversight at that point in time, rather than picking it up as later as something we've got to fix. It's actually, what can we do locally, because I think that's the important piece that we've
what's the best option, isn't it, rather than going straight to expensive out road placement. Yeah. Okay, Sean, and then we're going to move on. Go on.
Yeah, just briefly to pick up the conversation we just had, really. This report was about specific answer around our insurance. And though your question does consciously or otherwise open up a whole raft of issues around this, which Michelle has answered and Teresa touched on, I think it's fair to say that it's a very multi-layered and complex area, and the combination of local capacity, the default to referral outside area that Teresa's just described, the needs of the patient, etc., are all of this. And we're working through all that, as Michelle described. We're trying to develop a different approach to it to try and maximise it. But I suppose primary purpose was just to bring this here in response to that specific answer.
Okay, I think it does give us a high level of assurance, I think, from my point of view. So. Okay, thank you. So we're going to move in. So Sean, Des, Amanda, Jane, we're going to move into the quality performance workforce finance, snappily titled kind of overview. My suggestion is I think we need to receive the information. I think we get a chance to go around this again in part 2, so we can have fairly detailed conversations. So I suppose this is just the opportunity to signal in public where we are with all those things, and then we can pick up some of the detail kind of later on in the interest of time. So I'm assuming you've worked out who's going first.
I'll pick up, that's all right.
Sean's going first.
Just for clarification, this is the report that relates to 25-26 financial year and the operational planning requirements that as a system leader, ICB, this pertains to, and it will not look like
our previous life. This is our previous life, isn't it?
The legacy of reporting and data availability and so on and so forth. This is the month 11 report, which includes the end of year data for urgent emergency care, but the month 11 refers largely to the majority of the rest of the data. So just in case you were wondering around the sequencing and content of that.
And this is a report, isn't it, just for clarification, that has been through finance, performance and contracting. So this has already been seen by your committee, hasn't it? So,
yeah. And I think just to signal that obviously we're doing some work behind the scenes, as we touched on at previous board meetings, to look at a different format and content, and mindful of your particular reference to quality. Obviously, we'll pick that up as part of that as well. So just bear with us until we finish this off, and the subsequent report, as a quirk of the timings, will reflect the fact that last Thursday saw the end of year superstats position for plan care come out, and you may have seen in terms of an NHS England release around delivering some end year targets. And of course, if you haven't seen it, the then Secretary of State's resignation letter to the Prime Minister did talk, amongst other things, about the fact that he delivered a number of year targets. So, but this is not in this report yet because the timeline doesn't allow it. So essentially, in very broad terms, we've delivered against a number of areas, but majority of the ones in the acute space have not delivered. That's been consistent throughout the year. There was multiple reasons for that. Although on urgent emergency care and on our CAT2 ambulance response times, they've been in a very positive position at year end. And that reflects quite a lot of improvement during February and March from what otherwise was a challenging winter period. Cancer, RTT for elective, and a number of other areas remain ongoing challenges for us. And the mental health area is largely positive, with the exception of one indicator where we put a more challenging trajectory at the back end of the year, Michelle.
No, don't give me that.
Reflecting your optimism at the time.
Challenge.
The conversation and stretching.
Yeah.
And as a result of that, we've not quite measured up in terms of the latter part of the year in terms of that area in relation to inpatient stay for autistic adults. Primary care appointments remain strong, and there are other areas related to that. And on dental, we've seen some improvement in access for children and people, but less so on adults, and we're looking into some of the core reasons for that. So in the interest of time, Chair, I'll leave that.
Okay.
Unless Des and or Jane and Amanda want to add to that, but we can come back to that later. Yeah.
We will come back to this, won't we? So Des, anything you wanted to add or?
Just a couple of things, thank you, Chair. So just in terms of, obviously, as Sean's already summarised, this is 25-26, so this has still got the information we had in last month from a finance perspective, and we haven't included the ICB position for month 1, which we do have and have reported out. However, just I suppose consistent with national reporting anyway, the ICB doesn't have a budget in a ledger at month 1. That's because of our national system. So it is just a very high level report, and we've reported on plan, but we are flagging in line with our risks that we flagged in our plan. Obviously, as Jane's already updated with the reorganisation, where we are with the reorganisation means we necessarily do have some double running costs going through there, which we're keeping an eye on.
They're inevitable, aren't they?
It's inevitable, and it was obviously flagged as one of the key risks in our planning submission. So just to be aware of that, and you'll be hearing more about that. And then just in terms of the 25-26 position, as we've rehearsed previously, just a reminder, because we posted an ICB deficit, we do have a regulatory notice that's attached to that we're going through the audit committee.
Okay. Teresa, do you want to?
Yes, you know what I'm going to say. And that is that we posted a deficit position at the end of the year because of the change in rules during the year, which were that we were not in receipt of deficit support funding because our providers didn't achieve their financial plans. If we had been in receipt of the deficit support funding that had been part of our original agreed position, we would have posted a balanced position at the end of the year.
It was a removal of funding as opposed to an overspending.
Absolutely.
Yes. Okay.
I just second the importance of that, because what we can see clearly from what we've looked at is the controls and sticking to budget is there. It was that circumstance. So just the importance of that.
Yeah, that tipped everything, and I think that is important to kind of understand. I think there's a difference between spend, and actually.
It's the so what of that. The so what is that the allocation that came to us was not as we expected, so therefore we can focus on that piece rather than the fact that we weren't in control of our. It's a very fundamentally different position.
Yeah. The strong and transparent control. Okay, so Amanda, anything quality-wise you want to add?
3 things. One is at this public board to give assurance around the work we're doing around corridor care. So we've had our first system quality group with providers. There's more work to do. We're seeking assurance around their plans for winter around corridor care and the impact of caring for patients in temporary escalation spaces, which links to falls, pressure ulcers, and certainly to infection prevention control. So we did work also at System Quality Group around infection prevention control across our patch, and there is further collaborative work to do around that. We are also doing key lines of inquiry into cancer pathways from a quality lens, and we will report that back through System Quality Group and Interquality Committee around that. And then just to note, Chair, so we've had 2 maternity services on our patch that were deemed inadequate in CQC inspections previously in 2023. And it's just to note that there has been significant progress in those 2 services to the point where we are now seeing the regulatory action that was taken being lifted in both providers, which is good news for our women and birthing people across our patch.
Excellent. And don't get excited, Sean. I heard the word winter. That's all you understand.
Yeah, I just want to put a marker down, really. I think I've read the report. This has given me information. It's not given me assurance. In the second part, I can see that. Yeah, because it's much more detailed, and it's actually, this is what we're doing about it. And I don't understand, and it's a discussion that we need to have. why that report in private board isn't in the public domain.
So we can work that through, and I think it's good pushback. So let's work that one through. And I kind of think we should understand the issue and gain assurance or not assurance as a board, and that's really important. And assurance is different to reassurance. So there is something around, we have an opportunity to start to think about how the board would like information kind of presented. And I think we are in and that will change in the future as well. So we're in that strange place at the moment, aren't we? You know, the hangover of the old world into the new world. I think the opportunity is there through the committees as well, because part of this is about our delegated assurances to committees. So some of this is around the quality committee should recognise the quality stuff that's being presented. So it's how we move this forward in that intervening period. Once we stop reporting on last year and start to think about this year, I think that then becomes even tighter. So we can pick that one up, but I think it's I understand the point that's there. Teresa, do you want to?
Well, just to reinforce what you started to say in terms of the change this year will be through how we manage the contracts with the providers rather than trying to just report on their performance and work with them on it. It is actually active contract management.
And it's the lever we get from that. And I think that is the key kind of difference moving forward. So Jane, anything on workforce in this bit?
Yeah, I'll be very quickly. And I think you saw most of this last month, but we still have this continual tension between whole-time equivalent reduction delivery and pay bill management. So the end of the year for workforce was only 1.1% over plan. Overall, there's some peaks and troughs sat within that, and definitely really good performance on agency. The target was 30% reduction. We achieved 33% across the system. So there's some good news stuff sat in the workforce numbers, but you can't look at that divorced from pay bill, which is significant overspend. And I know the providers themselves are quite keen because we've stood down the pay bill and agency management committee now because of the change in our role, but they're quite keen, I think, on building on the work that was done there. And I think it's important that that carries on because that will help those providers in next year.
I think that's right, James. So Teresa, Jane.
So I think for people listening, it will be hard to sort of understand in a way or plan and then the pay bill and the what's giving rise to that pay bill and the plan, and obviously the mismatch that you're talking about, and it's not a single factor, especially as you say, you know, the reduction in agency utilisation alongside it. I think for me, one of the most fundamental things is the failure to triangulate the efficiency programmes that are required within our providers with the workforce that is required to deliver those efficiency programmes and, you know, deliver a redesigned service on the back of it. And it is that, so it's a plan in isolation to taking on board the efficiency programmes and the impact of that. And that's why we've got this dissonance with the plan being in numbers being fine, but in money not being fine.
Yeah, I think that's right.
That and the triangulation between the finance ledgers and the workforce plans. So and there's only one organisation, Michelle, that has cracked this, and the other providers are on with trying to learn from what Humber have done to help with that triangulation.
Yeah, that's the I think that's the key to this, isn't it?
It really is, yeah.
Okay, so we can pick up more of this kind of later on, but that's kind of the headline kind of position on that. So, Nigel, I'm going to move to speak up. I think the actions in this are probably wrong. So there's something about receiving the report. Then there is the piece, the really interesting piece that kind of gets floated in the covering report, which is about we need to kind of look at freedom to speak up in the new world. So we've already said, so one of the things that we've looked at is that clearly we would like the chair of the Remuneration Committee, Dean, to become our champion around freedom to speak up. And we do need to think about the infrastructure that sits around it. So there's a point in here which is about needing, I think, in the context of the world, to review the strategy and bring that back. So that's probably, rather than approving a strategy, I think what you're asking for in the report is that we take the strategy away and and almost kind of make it fit for purpose in terms of the new world. That's, I think, what the piece of work is. It's not about approving the strategy, is it?
No. So this is under the, thank you, Chair. This is under the assurance section. What I would like the board to be aware of is that we do have a policy compliant freedom to speak up model at present. And what we've been able to show in the report is the numbers, very small numbers that do come through to freedom to speak up in an ICB. What we need to do is think about future arrangements now. We're a strategic commissioner. And we also need to think about how that a more networked approach could be implemented across primary care services as well. As that's something that Zoe and I chatted about earlier on. And out of that, then the request would be that we go away with the policy and the strategy, review it, come back with a refreshed version of that. But the assurance today is that 6 monthly reporting that actually the freedom to speak up is operating in the background.
Yeah. I think that's right. And of course, the National Guard is one of the things that goes in the
National Guard.
in the reshuffle. So the national office around it, there's still a requirement, and everybody has to have a freedom to speak up arrangement. So this is about the assurance from the ICB's point of view, and I think there's a list in here which talks about the types of kind of things that have been referred. I was commenting to Dean before that some of these are HR ones which can then be sent back to HR route. So actually the route of getting to freedom to speak up, it's not always about freedom to speak up issues. And I think we probably do have an opportunity, don't we, to think about rebadging, relaunching, re-energising freedom to speak up in the new world. And key to that is having a strategy which may be not a million miles away from where we started with this, but does need to be redecorated in the context of strategic commissioning ICB. And that conversation with primary care, I think, is really significant, because how do we support freedom to speak up with primary care as a commissioner, accepting that primary care is big and complex and includes a number of different things apart from GPs. So questions on the freedom to speak up. So I'm going to take Teresa.
I've got some comments.
And then Sue. So we've got Teresa and then Sue.
So just picking up on the point that you made around, if you like, relaunching it in the new world. I think one of the things that we've got to do is to make sure that the communication on this and the information on this is properly understood. Most of the information coming through is, or representations made through this, is actually HR related, and actually, so it's in the wrong place and gets redirected. So that's the first thing to say. But obviously we want to encourage people to speak up if there are concerns about things. So there's always a balance to be struck in terms of telling people to use the right way, if you like. I just want to reinforce the importance of this, irrespective of the National Guardian gone. And, some of the if you like, the recommendations from Lucy Letby inquiry and things like that, in terms of the importance of freedom to speak up and people feeling that they've got the opportunity to raise concerns and be supported in doing so. We cannot underestimate how important that is. In relation to where we go next, I think we on the basis of all I've just said, I think I would particularly ask that Dean, Jane and Nigel review the approach, the strategy, the communication bit about getting the right processes in place. But also just looking at the tables of reports that have come in. We've got two very long-standing, one particularly long-standing and one medium-term long-standing. And I think there's something around, already monitoring through quality routes. Well, monitoring for how long? Is that actually an action in itself? I just think we need to be much tighter around the actions and the closure, if you like, of these
And that's probably part of that wider piece of work. So I'd really support that idea of you getting together and kind of doing a number of things, one of which is looking at the infrastructure we need to put behind freedom to speak up, because, you know, right at the moment, we won't have the infrastructure we currently have that sits around it. So something there about the strategy being fit for purpose for the new world is that. And then also, I think there is something about that assurance as to how we manage those things that kind of arrive. And actually, if some of those delays are about, they're acceptable delays in terms of how we manage this, or if this is just, so how do we close stuff down in an appropriate way without people feeling as though we're not kind of interested. So there's probably a number of bits and pieces which probably is worked up, probably come through execs and then back to board.
It's more than just showing somebody that we're interested. It's actually, if something's been raised that is of concern, actually we're taking the action that's required on the back of it. And that's and I know there's got to be, you know, the confidential nature of a lot of this is really important, but somehow we've got to be explicit in our assurance that the board gets that we're actually acting on these as well.
Yeah, that sounds like that's the piece of action to do. And I think we've dropped out of timescale a bit with this one, haven't we? So the next report is probably due sooner than we anticipated, isn't it? Because I think this due in March.
In March. Yeah.
So if we use that as the next, I mean, the current process exists, doesn't it? If we use the next touch point at the board as being this is how we're going to go forward, that feels as though that might work. Yep. So,
going back to something that we've talked about earlier, I think this is a real opportunity to actually highlight outcomes.
Yeah.
And what I didn't see was it was linked to current evidence received from staff survey results and such. So I think it's about how the objectives and the outcomes are linked directly back to evidence, so that then you can track whether there is impact.
Yeah. And actually, some of this happens as a result of it. I think that's quite important. So we can incorporate that into the conversation.
Sorry, I just because so I think that's absolutely right. But I just want to think about, and I'm speaking as I'm thinking. There's, as you can see from some of the referrals we get, it's not actually about our ICB.
No,
it's about services that we are commissioning. So I take that point. But it's not the only thing we need to think about. We need to look at this through our commissioning lens.
Yeah.
And it is the user element to it as well, which goes back to the feedback we're getting. Yeah, absolutely.
Okay. So I'd be happy to receive that. There's the overview of where we've got to. And there was internal audit, wasn't there, Nigel? And recommendations of the internal audit are in the paper, and those actions have now been kind of implemented. So clear set of actions there in terms of Nigel, Jane, Dean. Thank you for agreeing to carry that forward. And we look forward to seeing you in a couple of months' time. Superb. Okay, so we're going to move on to what's interesting on my board briefing here. She won't be here. It says James Crick to lead Freedom to Speak Up. Nigel,
yes,
give you that option because you're here.
No,
just got to change that.
Fine.
Okay, so insights reports. You've got a copy of all of the insights reports from committees. There's quite a long list of them. I wasn't anticipating going through all of them. They are there for kind of information. As always, these are old world in some ways. So they're committees when you weren't around. What they do give you is just that kind of overview. I'm going to hand to Jane. Anything you particularly want to say about the insights reports?
Not that you've not just said, no, unless people got anything on any particular committee that they want to, but you've got copies of all of those insights reports.
Yeah,
they're quite clear, comprehensive.
And for the new for today non-exec directors, the insights report kind of flow out of each of your committees. So they're the assurance to the board of the issues you've talked about, anything you want to escalate to the board, and the articulation of your high level risks. We do have an opportunity to kind of do some tinkering with the insights reports, but we then need to think about how that then ties into the work of the committees as well. So very much a kind of work in progress. And it almost kind of has to match where committees kind of get to, because you will be reporting on other things, but actually that line of sight from the board to the committee is incredibly important. And actually, once we get to the point, so next month, we will be using our development session to do some stuff about risk. So I need to tell you, you're all going to get a survey about risk coming to you imminently this week. which you do need to complete and return. It is the one about raw chicken. To warn you, it's the one that involves raw. So any nurse in the room, there's a question about raw chicken. Answer it honestly. I bet it's on there. But then the risk stuff will help us look at the risk registers. We agreed the strategic objectives, so it all starts to kind of come together. So this is very much a point in time insights report. We need to do something similar, but we are open to a conversation about tweaking, but I can't guarantee that we will say yes. Any questions about any of them? Super. Okay, so Jane, over to you. So Breakthrough Programme Board.
Yeah, I'm looking forward to talking to everybody about this actually. So for those that are new for the moment, we've been running a breakthrough programme, which was a workforce programme for the last 4 years. But with the shift that's been happening in our approach, we still kept parts of breakthrough, and we've got some elements working on breakthrough. The things that have changed and expanded during the last year are particularly the complex area around work, health and skills that's been unfolding and developing. And that means that we've been working closer with, particularly with mayoral combined authorities, for example, and some of the funding streams that are sat within that come directly to us. Some of them go directly to mayoral combined authorities. So you've got things like Workwell, for example, where the funding streams do come to us. You've got things like Connect to Work, and we've got trailblazers, accelerators. I can explain all of that to you in as much detail as you would like at any point that you would like, probably outside of here. Because it's quite a complex, therefore, landscape, we're looking at getting approval today to set up a board committee that particularly looks at work, health and skills. We've got 3 mayoral combined authorities, for example, all running their own programmes around this. I chair the Hull and East Riding Skills Board and sit on that mayoral combined authority board, which means we've developed some quite comprehensive partnership work in there, but we work with York and North Yorkshire as well, and with Lincolnshire. So because of the complexity of this, we feel it's right as part of our programme to have a board committee, because otherwise there's the opportunity for it to run off all over the place. It would be really difficult to manage those competing areas. Jason, you've been leading our breakthrough programme for the last going on 3 years, I think. And therefore it's suggested that you will chair this board, although you also chair this board. So that's what I'm bringing. I can talk in as much detail as you want, but I'm conscious of time. I think it's one that's, in my view anyway, easy for the board to support, but I would be interested in the board's views.
And I think this is about the board approving all the pieces of work, the mechanics then of kind of terms of reference and kind of outlining what the programme is. So I think there's an opportunity to do some shaping there. So I think this is just about the board saying, we recognise the need for the programme board, go ahead and do the work, rather than us do all the work and the board say, we don't think we have a programme board.
It is worth saying, so the widening access demonstrator work that's in here that we've done is of great interest. So Skills for Care have done quite a bit in it. I ended up presenting at one of the Alan Milburn sessions around it. We've had real success on it. So we've got real opportunity to make a difference in our communities actually with this, if we get it right, with the right kind of board wrapped around it.
Yeah, and actually some of this is that key element linked back to neighbourhood health. So this is some of the stuff I think we were talking to Claire Fuller about last week around how we align all of this.
So I have two comments to make. I think the first is I don't think it's optional that we're not in the space to influence the future workforce, given the changes that we're going to be commissioning. So I think there's that bit. Yeah. I think the second piece for me is it's the higher ambition that we truly facilitate anchor institutions for local community benefit. And that means that the NHS pound effectively should be spent nearer where people access and use it. And I think that's the other arm to this, that we have a chance to influence through doing some of the work around a different workforce model to benefit local communities and be that anchor institution which influences some of our commissioning decisions.
I think that's exactly right. I think that's exactly what it's about. Michelle.
Yeah, no, thanks. And obviously great about the breakthrough programme that you did on the workforce. So I'm great that you're reflecting on that and following that. I think it's a really, really good idea for the FCB because it does link into that health inequalities, population health, and can help, shape that strategic commissioning picture. I'm not anxious. I just think we need to be careful that we actually link in, and probably in the detail, Jane, other organisations, because I know certain organisations have done a lot of work on that social economic regeneration and linking into the MPs and the mayoral office, etc., etc. And I know that we've all submitted things into the Alan Milburn piece of work. So I just think as long as we triangulate that we're not duplicating, the FCB could set that overarching strategic piece. But I won't want to lose what we've already got. And not doing this.
And I think very much, with any reassurance, I think very much this is a partnership programme.
Indeed.
I think it enables us to continue to do some of the stuff that I think was incredibly strong and benefited us through breakthrough, which for those people who went around for it, was very much about the ICB convening the system to kind of play to its strengths. And I kind of think it's very similar to that. I think very much this is about saying everybody has something to contribute. So how do we put all of that energy around future roles? And there's something here for me about the really important stuff that we did around portability. The idea that, people can move with ease into different roles across the system. And actually, we will need to think about portability when we get to the point to talk about neighbourhood health and that whole new workforce and the future role of AHPs. I think AHPs are going to be incredibly valuable in delivering neighbourhood health. So actually, all the work we've got, foundations we have with the AHP work, the social care with skills for care. So I think this is the ability to bring stuff together. So I think probably we need to give sufficient time on the next agenda, Jane, to kind of work through the terms of reference and the work plan. And actually, I do think that strong emphasis on partnership and for all sectors and building on what people are doing already, I think is incredibly important.
It's probably worth adding in as well before you ask for approval in terms of the organisational change and the standing up. The people that are in post that support this work are already in post, and therefore
and standing up
and stood up. Yeah. Stood up.
So I just wanted to test my understanding. I'm new today, not new tomorrow, but when I'm looking at this, I'm almost sort of seeing there's two lenses that they're intact on this. There's what the programme needs to do to make sure this is happening in our communities and out there for the whole population. But then actually, are we actually doing this within our own organisation as well? Is it right that there's those two lenses and both of those linking? Yeah,
there is. Yeah.
Good. Just checking my understanding.
And very much it's about leading and being a partner. I think it's that tension between the two. So actually, in some ways, this is the ability for us as an organisation thinking about our strategy moving forward as to what is our own commitment to living what the partnership board kind of talks about. So
influencing the wider elements.
Yeah. And the opportunity we have this as well is like wider relationship with the private sector and business. I mean, that is incredibly, we haven't really probably maximised the opportunity we have. So
if we get this right, it's great for us as an organisation, but it's actually great for all of our citizens and the impact that has as well.
I may be biased, but I think we do this really well. Okay, so I think that's a green light there. So Rachel can do some terms of reference. Wonderful.
Thank you, everyone.
So items of information, you've got the good news briefings. Any other business? There's one item. So you remember last time we approved our constitution. It kind of went off to NHS England. They said that's fine, absolutely fine, new constitution. We did make one omission in which is a person. So in our new structure, I think I've referenced already Alex Seal in terms of her role as, I'm reading it from my car, Director of Performance and Contract Delivery, Neighbourhood Health and Primary Care, as a participant at this meeting. What we haven't done is included that role within the Constitution. So NHS England have agreed that we can add Alex in without having to go back through the route. I just need the board's approval to add in Alex Seal's role as a participant into our Constitution. Does anybody severely object? Is everybody happy with that? Okay, so Alex is going to be added in, so we can just do that, Mike. Okay. So, 30 minutes of meetings. I know we have gone rapidly over time by half an hour, but I think we've probably had the conversation we need to have this morning, which sets us up for the conversation this afternoon. I think you'll sense there's an awful lot of change kind of happening around us at the moment. the opportunity to, I think, reflect back certainly some of the stuff that we've been doing more recently and that positivity in terms of, where we are now in terms of things like neighbourhood health, which will make the biggest difference, the opportunities we've got through the NHS Act, the opportunities we've got through engagement with communities, really starting to think about how the role of committees supports that and committees offering assurance and the role of the board kind of moving forward. And really strongly that message, and I heard that loud and clear, and I'm so pleased that I heard it. There is so much to be proud of here that despite the challenges we are doing, we all just need to shout a little bit louder about what we're doing, because actually that matters to staff, it matters to communities, and actually it is making a huge difference every day. So we just need to be slightly noisier, but probably not in the next 10 minutes when we're about to do some training, probably after lunch now, Mike.
It's fine.
Okay, thank you very much. And thank you very much for sticking with us this morning. And we will see you all soon. We will see you in July.
Thank you.